the meantime, feeding.
Assalamu alaikum. Good afternoon, everyone. Today we'll continue our academic activity. We'd like to welcome Dr. Abdurrahman Al-Qahtani, he's a cardiological intervention consultant. Today we'll talk about the mitral minimal invasive in mitral clip and robotic mitral valve surgery. And the next lecture will be pathophysiology and diagnosis of aortic dissection. The third lecture will be management of aortic dissection, and we'll have our journal club, arterial versus venous conduit in capital. Dr. Abdurrahman. Dr. Abdurrahman.
Okay, sorry, I was on mute. So good afternoon, everyone. My name is Abdurrahman Al-Qahtani. I'm an interventional cardiologist and a structural cardiologist. I've been back to the country for over the last 2 years. I've worked as a consultant interventional cardiologist and a structural cardiologist in Northern Ontario for 3 years before coming back to work here. So my talk today will be tailored toward the role of percutaneous edge-to-edge repair, also known as mitral clip, and a treatment of severe mitral regurgitation that is not surgically appropriate. Okay, so I try to make the talk as concise as possible. I did not touch on other aspects of intervention that could be done to the mitral valve. Percutaneous intervention to the mitral valve, there's many out there. We just focusing on mitral clip. Also, I'm not approaching this from a surgical point of view. I think this might be addressed by one of your colleagues or one of your consultants. So I'm going to start with a clinical case, if you don't mind. I think it's always good to have a clinical case orientation, and that will take us around the topic. So this lady I just saw 3 weeks ago, 65 years old lady, dyslipidemia, hypertension, type 2 diabetes, and coronary artery disease. She's known to have ischemic cardiomyopathy with ejection fraction 30%. 3 years ago, she had a major anterior MI, end up with a BCI to the LAD, followed by BCI to the LCX and RCA. She was triple vessel disease at that time. She was declined for surgery. It's not clear to me, to be honest, why she was declined. Is it because she was in shock at that time and she was not doing well, or there was other reason? It was done outside our hospital. But to say reviewing her coronary anatomy, she would have been a good candidate at that time if she was stable and able to undergo coronary artery bypass surgery. She would be a good candidate given her situation in terms of coronary artery disease, triple vessel, and diabetes. Anyway, this patient has recurrent admission to hospital with acute decompensated heart failure. She is maximally managed on anti-heart failure medication, and she is known to have a severe secondary mitral regurgitation. This is a transesophageal echo showing basically an LVOT view. And you could see here, I'm just going to point out if I can, this is your aortic valve just for orientation. And this is your mitral valve. This is your anterior mitral leaflet. This is your posterior mitral leaflet. As you can see here, there's a severe swirling jet directed posteriorly in this patient. And every time she comes, especially when she gets more decompensated, the degree of the severity of MR become worse. This is a different view. This is a four-chamber view, and you can see how strong the jet and how bad the jet. And you can see it's engulfing or hugging, what we call it wall hugging. It hugging the posterior wall of the left atrium. Okay, so this is her baseline ECG. Her ejection fraction remains to be around 30%. The transesophageal echo does not show it, but her LV is dilated, and she does have a regional wall motion abnormality. So we're going to talk about the impact of mitral regurgitation. So what do we end up having if we have untreated severe mitral regurgitation? So when you have mitral regurgitation, it increases the load and stress on myocardium. This leads to muscle damage, and eventually you get dysfunction of the myocardium that lead to dilatation of the left atrium, that worsen the mitral regurgitation, and it become vicious cycles, and it continue. The 1 year mortality of patients with severe mitral regurgitation that is untreated is about 57%. And you can see here that patient mortality even get worse with the type of MR. So patients with severe MR tend to have a significant worse prognosis over 8 years if their mitral regurgitation is not treated. We know that mitral regurgitation is undertreated and underdiagnosed. It's present almost twice as much as aortic valve disease, yet it's not treated appropriately. For those who present with severe mitral regurgitation, the decision to operate on those patients is representing less than 50%. So less than 50% of patients do not get treatment, and that may be related to because of their age or their comorbidities or the degree of LV dysfunction. And that's something you take into consideration as a surgeon, the frailty of your patient, can they tolerate the procedure, and also can they tolerate it from anesthesia point of view, especially with severe LV dysfunction. When we take every single valve and look at their prevalence and the percentage that are treated of that, you'll find that mitral regurgitation represent a big chunk of all the valvular disease that you deal with, yet less than or about 1.5% of those patients are treated. So we have a large population of patients with severe mitral regurgitation, and yet those patients are undertreated. So there was multiple percutaneous approaches to help with the mitral valve, and we've been working around with many things until we came up with the mitral clip and start perfecting mitral clip. So with the mitral clip, I'm going to show you what is the mitral clip like. So this is the mitral clip. Basically, I'm trying to give you volume. So as you can see, let me take this down. So basically for this patient, I'm gonna go bring the video back a little bit, okay, from the beginning. So this is the device, you're looking at the device, and the device, the mitral clip delivery system. we gave, again, access through the femoral vein, and then we advance into the right atrium. Once we reach the right atrium, we cross the septum into the left atrium. A specific position we have to find to cross the septum that allows to do the procedure. After crossing the septum, we advance the special wire, and then we advance the delivery system for the mitral clip into the left atrium. You can see we're above the mitral valve, anterior leaflet, posterior leaflet, and then we bring the mitral clip. When we bring the mitral clip, we oriented it to get into the position where we think is appropriate. And this is using the TE guidance. And after that, we come down, we cross the mitral valve, and trying to orientate it with the jet where the jet is more significant. And then we come up with those two arms of the clip. As you can see clip, we just bring them to clip it. And once we get the two leaflets together, we grab them, and then we deploy the clip, and we assist the reduction in the mitral regurgitation. We create two orifices. This is also known to be the two orifices created by the alveolar stitch. And the whole concept of the mitral clip came from the alveolar stitch to close mitral regurgitation. If we were not happy, we'll change position, we'll capture again, deploy it, and then assess. If we find that the valve, the position is appropriate and the reduction is appropriate, we leave it. And over time, it grows some connective tissue around it, reducing the mitral regurgitation further and making the mitral clip part of the mitral valve apparatus. So what do we have in terms of mitral clip evidence? So over the last 16 years, we had a lot of trials. You could see the first case was done in 2003. Then there was two major trials, the Everest trials, and then the Everest high-risk trials. And those were the first trials that were attempted in patients who are high surgical risk or prohibitive surgical risk. And then they could not undergo surgery. Therefore, they were being allocated to this new device or new technology. And then there was other study coming along. The two largest trials to date is the COAPT trial that you can see the abbreviation there, and also a mitral clip trial from France. So we're going to talk mainly about the COAPT trial in this study. So currently, we have enough evidence that the mitral clip is the safest and the most effective percutaneous device. There's three major randomized controlled trials. There's thousands of publications on it already, and more than 100,000 patients done by this device so far over the last 16 years. It's the only device that has proven durability outcome up to 5 years, safety and effectiveness. Multiple trials has been published on that. And all those trials were assessing together the safety, the efficacy of it in reducing mitral regurgitation, and that translates into improvement in heart failure class and also improvement in LV remodeling. As you can see from a severity of MR over those trials, this is multiple different trials, Everest, Realism, all those trials were designed mainly to test the efficacy and the safety of a mitral clip. And you can see the gray color is those treated with medical therapy. Those are basically patients who received a mitral clip, and those who have 2+, less than 2+ mitral regurgitation, and the dark blue color is less than 1, which is mild to moderate. And as you can see, patients who received mitral clip and the new generation of mitral clip, the NTR and the XTR, there's a lot of patients who are 2 or less than 2, so from mild to moderate MR after the use of the mitral clip. Those patients, the majority of them were severe mitral regurgitation. Some of them is moderate to severe. And we have real-world evidence coming from registries. The largest registry was in Germany, 13,000 patients treated from 2011 to 2015. And the safety and effectiveness of mitral clip was shown in this study, as in-hospital mortality remains stable around 3.1%, and MACE rates will remain stable between 5.6 to 6.8, despite increasing inpatient age and the complexity of patient that we were dealing with. There was 5.4 fold increase in patient-treated mitral clip. So if you look at 2005, for example, compared to 2015, that number has doubled 5 times. Also, the age of patient, we started to do more complex and older patient, and we started to do more heart failure, severe heart failure patient. We were trying to avoid this at the beginning of the studies, but now we are doing actually more severe heart failure patient. And there was also the TVT, which is the American Registry. They looked at the 30 days and 1 year events. And they found that the in-hospital mortality remained low at 2.7. The German one was about 3.5. Discharge from home discharge to home was almost 90% of the patient, and the actual procedure success was 91%. And median length of stay in hospital for the procedure is about 2 days. And you can see on the right side that the post-procedural MR less than 2 was achieved in 92% of patients. So imagine you have a patient that comes with severe MR, class 3 heart failure, and then you do this procedure, which literally takes us about 1 hour to do. Patient is intubated. We can do it conscious sedation, but it depends on what we do. Because of the TEE, it makes it hard for them to be comfortable through the procedure. So we tend to intubate those patients. And within 1 hour, you come out and you have an acute reduction in your mitral regurgitation from severe all the way to mild to moderate. And that actually translates into improvement in their heart failure, their quality of life, their walking distance, etc. We're going to talk about the COAPT trial. COAPT trial, if you look into the literature of the mitral clip, COAPT trial is the cornerstone of what we do right now. Like, it's the trial that is giving all the evidence that we do it. Before it, there were ever small trials, and there was another one called MITRA France, which is a mitral clip trial in France. It's a different population between COAPT and MITRA France, and therefore we have different results for them. So this trial was a trial that tested this device against medical therapy. So it randomized patient who was open label, about 614 patients with severe heart failure and moderate to severe mitral regurgitation, so 3+, 4+, who remain symptomatic despite maximum medical therapy. And when we talk about maximum medical therapy, we are talking about, top-notch medical therapy in heart failure patient. It's not like they're only on ACE or beta blocker. No, they're on ACE, beta blocker, RNI, like Entresto. They're also on mineralocorticoids or spironolactone antagonist, and they're also on the SGLT2 inhibitors like empagliflozin or dapagliflozin. So, like, you have 5 of major medication that they're already on, apart from diuretic, etc. And yet those patients are not improving yet. So they were randomized to mitral clip plus goal-directed medical therapy, or goal-directed medical therapy alone. And they looked for primary endpoint from effectiveness and safety point of view. They were looked at all heart failure hospitalization among 24 hours, and also from safety, freedom from device complication through 12 months. Patient, they screen a lot of patients. Those with a heart, preserved ejection fraction, they didn't look at them. They took patients who are reduced LV function, and then looked into their class of heart failure and picked up class 3 and 4, so very severe heart failure with moderate to severe, and enrolled them in the study. And they looked after 2 years, when they published the trial, they looked into their outcome. So the first one, they were looking at all-cause mortality. And what they found, that patients who were treated with the mitral clip along with goal-directed medical therapy, they had significant lower risk of death compared to patients who were treated with the early goal-directed medical therapy. There was 38% reduction in mortality in patients who received mitral clip, and the number needed to treat, which is a very, very important number, is 5.9. So it means that you need only to treat 6 patients with mitral clip to prevent one death, and that is very good number to, looking at that. They also, at 3 years, the benefit of the survival continue and the reduction in mortality continue even at 3 years. As you can see, the curve continue to separate. And the recommendation from the European Society is that if a patient is indicated with severe MR and can undergo CABG, ejection fraction more than 30%, then surgery is the primary things to do. But if a patient is not surgical candidate, then it's a class 2A to consider a mitral clip, and that's at the time of publication of the COAPT trial. Those are the heart failure medication that I talked to you about. So ARNI, which Entresto, vasodilator, ACE inhibitors, ARB, calcium channel antagonist, digitalis, inotrope, samidorone, any of those medication that patient needs to be on. There is a 5 major medication that they need to be on, and then other medication to be added as needed. And when we look at the number needed to treat, remember that the COAPT trial, you only need to treat 5.9 patient to prevent 1 death. And when you looked at the COAPT over the 3 years, the number is about almost 8. So 8 patients, you need to treat 8 patients over 3 years to prevent 1 death. If you look into major trial, which like Entresto, we consider it a very good trial with good medication, you need to treat 40 patients to get to prevent 1 death. And the same for CRTD, ICD with medical therapy, you need to treat almost 25 patient to prevent 1 death. So a mitral clip is very good in reducing mortality if it's given to the right population with maximally tolerated medical therapy. Mitral clip is not only the device that shows survival, improving survival of heart failure patients with secondary MR, but also it's reduced the rate of hospitalization. Also, it improved the reduction and sustained the reduction in mitral regurgitation and improved the quality of life and functional capacity. We will touch on that. And it's safe. So 96% of patients are free from complication. When we look at 2 years, patient with mitral clip have reduction in heart failure and hospitalization, 47% relative risk reduction in hospitalization, and you need to treat only 3 patients to prevent hospitalization for heart failure. At 3, it persisted, and you need to treat 3 patients to prevent hospitalization. And in summary, basically, the COAPT trial showed that mitral clip improves survival by reducing mortality, reduce heart failure hospitalization. It does reduce mitral regurgitation, improve quality of life, and safe. In terms of quality of life, they used the KCCQ score, and it showed that patients received mitral clip after being treated with it on maximum medical therapy compared to medical therapy only. There was about 2.5% more likely to experience significant improvement in their quality of life. And looking at their 6-minute walking distance at baseline and then 12 months and at 24 months, patients who received mitral clip, they continue to have a better 6-minute walking distance compared to those who just been on medical therapy. You can see the difference, 174 versus, 203 meters versus 152 at 2 years, and 256 versus 188 meters at 1 year. So there is definitely improvement in there, also 6-minute walking distance. As for the class of heart failure, you can see at baseline that there was class 4 was representing almost 20% or 10%, and then the class 3 was representing almost 40% of those patients to 50%. And you can see at 4 months, the class of heart failure 3 and 4, they are significantly reduced, and there is improvement in class 2 and class 1. Again, this is the same things in terms of the degree of mitral regurgitation. You can see the baseline, there's 3+ or 4+, those were enrolled. And at 2 years, you can see that the majority are less than 1 or 2+, which is basically mild to moderate mitral regurgitation. And in terms of a device-related complication, there was no significant device-related complication in terms of detachment, embolization, endocarditis, mitral stenosis. After that, there are, as you can see, very small percentage. There was no endocarditis published. There was no mitral stenosis. And any device complication required non-elective cardiovascular surgery. It's just one patient over the last 3 years from that study. So very small device-related complication, which in other words is very safe device. And in terms of progression of heart failure, there was few patients that went into LVAD, and those required heart transplant in the future. So it still remains a very good intervention to reduce symptoms, mortality, and also remain efficacious and safe. So COAPT trial is a landmark study in the management of heart failure. At 2 years, you needed to treat about 6 to prevent 1 death, and you needed to treat about 3 to prevent 1 heart failure, and the number remained almost the same. And COAPT showed us that mitral regurgitation is not it's not a marker, but it's actually a cause of death. And treating that appropriately with percutaneous intervention, if not surgically feasible, along with cold-directed therapy, does reduce mortality. Also, it's improve quality of life, as well as improve the ability to reduce the hospitalization for heart failure. So I'm going to briefly touch on a Mitral France study. And the reason I brought it, because some of you may look up the literature and found that there is conflicting evidence. And what I mean by conflicting evidence is that COAPT trial showed us that there is improvement in survival, there is reduction in hospitalization, there is improvement in quality of life and 6-minute walking distance, and also all the echo criteria. But Mitral France did not show that. So the difference comes from the definition, actually. So the definition of severe mitral regurgitation entry was a bit different between both of them. So in COAPT trial, the effective regurgitant orifice area was more than 30 millimeters. So what does that mean? In COAPT, patients needed to have a defect, a coaptation defect that is large, given them a severe mitral regurgitation. Okay, while in Mitral France, they took even a smaller one, like you didn't need to have a significant regurgitant orifice area, as long as it appears to be moderate to severe, they took it. Also, in Mitral France, they included a very dilated left ventricle, while they were excluded in COAPT trial, as we don't believe they did get a very good benefit. So that was a major difference. The other difference, that in COAPT trial, they made sure that all patients were treated with maximal medical therapy, while Mitral France was left to the discretion of physicians, so it was not necessarily always the case. And as you can see, that the acute result and no clip, or they remain to have severe MR, they're above 9%, while here about 5%. And procedure complication with Mitral France was higher compared to the COAPT trial. And patients who remain to have more than 3+ MR in the Mitral France was 70% less compared to 5%. So what that means is basically the success rate in Mitral France was lower, the complication rate was higher compared to COAPT, and the cohort of patients was also different. They were less regurgitant, less coaptation defect, or smaller, with severely dilated ventricle. So they didn't drive as much good benefit as compared to the COAPT trial. I'm going to skip this busy slide. And it basically comes down here to explain that the difference came down from the inclusion criteria and definition. So they were 2 different cohort group. And just showing that the safety, even in the Mitral France trial, was remaining very good. And their intention to treat primary analysis for all-cause death and first and planned rehospitalization for heart failure, there was no difference, unlike COAPT trial. And their New York Heart Association classification at 12 and 24 months, it showed some improvement, but it's not as much improvement as we saw in COAPT trial. And again, it's here. It showed that if you consider patients in this trial that were similar to the COAPT, there is a trend toward benefits from percutaneous coronary intervention. However, if you use a smaller regurgitant orifice and a patient who is likely not to respond because of the size of their left ventricle, then they will not seem to be benefit from the mitral clip intervention. They looked into their secondary outcomes, and again, it shows no difference between the two groups in mitral France. And there was trend toward the improvement with in terms of hospitalization, but that was not statistically significant. So mitral France study is a different cohort group who have smaller coaptation defect with severe left ventricular dilatation and severe LV dysfunction. And they did not seem to be benefit this group. And when even co-op trial, they did the subgroup analysis looking at the same population to see if that was going to be still there. And they showed that there is no mortality benefits, but there was some trend toward improvement in hospitalization, quality of life at 6-minute walking distance. Even in this group that doesn't seem to drive mortality benefit, they have improvement in their quality of life and 6-minute walking distance compared to people treated with medical therapy. So I'm going to be concluding with the case that I just showed you at the beginning. So remember, she's an elderly lady with ischemic cardiomyopathy, ejection fraction 30%, who has severe mitral regurgitation with recurrent hospitalization. She was discussed with the surgical team in our center, and she was declined for an intervention in the mitral valve. After discussing with the patient, we brought her for mitral clip. We're gonna start by showing you. So this is the mitral clip. You can see it here. Okay. So the mitral clip now is just sitting above the mitral valve, and this is the LVOT view where we have the anterior mitral leaflet and the posterior mitral leaflet, and you could see the arm of the mitral clip is opened in this view. And this is a 3D reformation of the mitral clip. And it's important in this view what we're trying to show that your clip has to be perpendicular to your mitral leaflets, because if it catches the mitral leaflet in tangential way or in a way that is like diagonally shaped, it's not going to be appropriate. It will tether the leaflet and affect the leaflet. So it needs to be very perpendicular to the leaflet that are opening in this way. It cannot be tilted to the right or to the left or clockwise or anti-clockwise. So we confirm that before we dive, and actually we do trials of diving to see if it dives directly, if it dives medially or laterally, because we have to adjust the direction of the diving before we grab the leaflet. And here, after we grabbed the two leaflets and applied the mitral clip, remember that the regurgitation was very severe. This view was posteriorly dilated, and you could see the significant amount of reduction already present with this mitral clip. You can see here that we measure the mitral gradient across the valve. And this is very important because whenever we put something across the two leaflets, there is a chance of creating stenosis. And therefore, here we are measuring the gradient across the mitral valve, and the gradient was 4. We are okay up to 5, but not more than 5. We have to come out if this is more than 5. And if we deploy it and it's 5, we cannot deploy any other clip if needed. And this is our final image. As you can see, this is the final image of this patient. You see there is a significant reduction. This is 1+ mitral regurgitation, and there is no significant stenosis. And after the patient recovered, the size actually has improved further. And this brings us to the end of our talk. Sorry if it's not as detailed as you may be looking for, but I do believe that capsule summary of what is this about is more important than the nitty-gritty and minutiae details that might not help you to remember in the future what's this all about. I'm happy now to receive any question, and you guys are more than welcome to pose any question to this or any interventional procedure after that. Thank you.
Thank you, Dr. Abdurrahman, so much for your valuable talk. I know that you are busy in your cath lab. Thank you for giving us this opportunity. And if there is any question from the audience or comment, he is welcome.
Thank you, Dr. Abdurrahman, for this such a nice presentation. If I may ask, what are the longest follow-up has been done for mitral clip in terms of long-term outcome? In terms, like I understand, very good results with the post-clip echoes and the follow-up, but I mean on the long term, how far reported follow-up longer, in terms of mitral regurg and progress?
Sure. So this technology was introduced in 2003. The initial trials was Everest 1, Everest 2. There was 100 in each study, like there was not a lot of patients. It was with the first generation of the mitral clip. Now we have 3 generation, also reaching the 4th generation now, the mitral clip 4G. And the follow-up for those ones are very small, up to 5 years. But what we have now, the largest trial, the co-op trial, we have 3 and up to 5 years follow-up. And those patients up to 3 years that we have published now, up to 3 years follow-up from the co-op trial, which we consider the biggest, those patients remain to do well. The freedom from rehospitalization, heart failure is very significant, and their mortality, the risk of mortality has plummeted significantly. When we look at Everest follow-up and Everest 2, there's few patients, and those patients still up to 10 years, some of them were there, but I cannot really give you a precise information on those patients because the number was not significant. They were small and they are underpowered to give us any information. So we are relying on the Mitral France study and also the co-op trial for further follow-up. We have data from registries, and those data from registries, again, it's a world, it's a real-world practice, and those are registry, and the follow-up in the registry is a bit mixed. But we have up to 5 years now that we can say for sure that it's very good up to 5 years. And I do think if it's chosen in the right population, and if it's been selected to the right group, and if it's done by an experienced operator, you will have a very good result.
Good, thank you. Doctor, what about the other minimally invasive, like the transcatheter artificial cords, or I think there's something about ring annuloplasty. Is it something only? Is it something in practice yet, or it's something coming soon?
Experimental.
Yes.
Experiment.
Yes. So no, Haytham, not all of them are experimental.
No,
so,
okay.
Yeah. So in terms of cord reduction or intervention on the cords, in terms of devices spanning the left ventricle and trying to reduce the size of the left ventricle, all of those ones have been tried. They were not very good, so they're not being used. There is a new device that actually works as percutaneous annuloplasty. So it's like you are deploying a ring, surgical ring, but that percutaneous. This has been used, and there are cases reported. There is no trials, big trials yet on that, but it's there, and it might be an option for percutaneous annuloplasty. That could be. But those ones, it's hard to go for any intervention now. If you have a very good intervention that has shown mortality benefits, has shown reduction in hospitalization, it is becoming hard. Like in those cases, you have to show additional benefit over the mitral clip to be able to create an economic, financial benefit of it. Therefore, those things that happening, they don't survive long because the competitor on the other side is an excellent product that's hard to beat. But what's available now, we do have percutaneous mitral valve, which could be surgical. We consider still percutaneous because it goes through the apex, the tendine, and normally this done by surgeons. And we could implant a mitral valve if you have a very severe mitral, very severe calcified ring. Also, if you have severe regurgitation, there is a new device, has not yet been approved by Edwards, where they create a nitinol ring. So basically, it's like a spring. It's like a spring that they deployed it around the leaflet, and after they deployed it around the leaflet, the valve comes and sits in it. This something is available, still not commercially available, but it's under research. So all the percutaneous attempts to fix the mitral valve from one way or another is still, not servicing to a level where they can become massively adopted.
Okay, thank you.
Anyone else? Haytham?
لين مساء الخير دكتور عبد الرحمن، يعطيك العافية يا رب.
الله. كيف حالك هيثم؟
والله تمام، ايش الأخبار؟ اديكم العافية يا رب.
يعطيك إن شاء الله. So any question from you or التخصصي that you're working at?
Can I make a comment on the the mitral clip, just to because we don't have to make a confusion with the kind of mitral we are talking about. We are talking about the functional mitral regurgitation, not degenerative mitral regurgitation.
Sure.
And my so the at least until until now the gold standard for regurgitant mitral for degenerative mitral regurgitation is still the surgical result, the surgical procedure. But for functional, yes, it's a big headache also for surgeons, especially in end stage or multiple comorbidities. So mitral clip has been definitely a blessing for the patient. I think that the message that the take-home message that we should take from the co-opt and the mitral fronts, the mitral clip fronts, is that you don't have to wait too much. I would remind that eventually the idea of the mitral clip is coming from an Italian surgeon who is Alfieri.
Yes.
Maybe the guys remember. That's why I'm commenting. I'll tell you, at some point back in Milan, they tried also the stitch without the ring. Why put in the ring then? Well, it didn't work. So definitely for the mitral repair and the Alfieri stitch to hold over time, you need a ring. That's why there is this big difference between the co-op. The co-op patients are better patients than the mitral fronts. They tried with the French. What they tried was to show the world where the result, the real world result, while the co-op was a different study aimed, to have the commercial license for the device and to promote the device in the medical world. That was a big difference. So the French were there to try. Okay, let's see what's going on when we do the real thing. And the real message between the two is you don't have to wait too much, because if you go for a very enlarged ventricle, the mitral will not make the difference, and also the recurrence rate will be higher. This is because, the ventricles is larger, and maybe in this patient, you may need a ring. While if you go early and you have a severe mitral regurgitation, the message for me, consider MitraClip earlier. Do not expect a patient coming back and forth from the hospital for this mitral regurgitation. Just discuss with your interventional cardiologist this option earlier, because the results will be better. And the difference is you cannot fix the ring. Okay, there are also devices now but they are not so easy. The MitraClip is much easier to learn to implant. The ring is a little bit more complex things. There is also an incident of heart blocks, so it's a different issue. So the message is you have to discuss the MitraClip in severe functional mitral regurgitation at an early stage. That's my opinion.
Thank you so much. I'm not acquainted with you, Dr. Claudio. Would you be kind to introduce yourself?
Oh, yeah. I mean, I'm a cardiac surgeon. I'm Saudi Arabia since 5 years. Before being here, I was here at Prince Sultan. I worked 2 years at Takhasusi at King Faisal. And my background is mainly Italian, but also a training in the Netherlands and sometimes spends as a consultant in UK. And the world is very small, because I came here at Prince Sultan after Calafiore quit. But basically, I never worked with him, but he is this guy who, did a lot for this center. Was one of my mentors back in Italy. So when I came at Prince Sultan's, I felt at home in a way.
Well, thank you, Dr. Claudio, and it's a pleasure talking to you. I think you hit the nail actually very nicely and appropriately. And I think you summarized, and this takes, the experience comes in place where you can just pick up the home messages from that. And I do agree with you that leaving the ventricle until it fails and become very dilated is not going to help. And a MitraClip does not help in those patients. We see them, if we had to do it for a patient that is severely dilated, and we don't get a good result. Like we try 2-3 clips, and sometimes we hardly manage to get that from 4+ to almost 2 to 3. And therefore, this is a sentiment. I agree with you that we should be tackling those patients earlier, as fast as possible, and trying to maximize their medical therapy. I do believe that, like I alluded initially, that the whole concept is adopted by the Italian surgeon Alfieri and his stitch. And as you mentioned correctly, that they were doing it, it was failing without a ring, and that because the LV was quite dilated. And I think in cases like that, even though that there is percutaneous mitral annuloplasty now available, but it's quite demanding, technically not easy, it's very challenging. And we are searching for those patients, and currently we review any patient who has severe, moderate to severe mitral regurgitation with recurrent hospitalization. We do discuss them in our combined round to consider any intervention of them earlier than later. So I thank you for your word of wisdom and your thoughts and your pickup of those highlights of this talk. I appreciate that. Any further question, or we can call it a day? Well, I think Hassan, we are reaching to the end of the talk. Thank you guys for giving me the opportunity to share some of my experience. Some of you do not maybe know me before, but currently I work in King Fahd Medical City. And as I mentioned at the beginning, I'm an interventional structural cardiologist, and my work is mainly toward the structural, TAVI, and mitral intervention in general. I also I do the complex PCI procedure. That's my niche in terms of recurrent intervention. So if you would like to reach me, if you want to ask a question, you're more than welcome today or any other day. and you guys have a great day. If there's no further question, we will adjourn our talk.
Thank you so much. Thank you, Dr. Abdulrahman. Thank you for your valuable talk.
You're welcome. Okay, you guys have a good day.
Hassan, you will present the next lecture. So we'll take a break for 10 minutes and we'll come back.
Abdul Malik.
Araya.
So the next is Hassan, then me.
Yes.
Okay, thank you.
You're welcome.
start? السلام عليكم. السلام عليكم.
عليكم السلام ورحمة الله.
طيب, can I start? عبد الملك.
اهلا حسن، تفضل. You can start now. حسن،
فقدنا.
اسمعني حسن.
Can I start يا عبد الملك?
هلا حسن.
Can I start?
يس تفضل.
واضح الصوت؟
ايوه واضح.
واضح؟
Doctor, your voice is clear. It's okay.
السلام عليكم ورحمة الله. Today, inshallah, I will complete our lecture, mitral minimally invasive mitral valve surgery. So we'll start with the introduction of the MIS. MIS does not refer to a single approach, but rather to a collection of new technique and operative specific technologies. These include enhanced visualization and instrumentation, as well as modified perfusional method, all directed toward minimizing surgical trauma by reducing the incision size. So it's all about the incision size and post-operative pain and the length of stay. There is the ideal mitral valve repair criteria, which should include small, non-rib spreading working incision and central antegrade cardiopulmonary perfusion with high definition magnitude 3D vision and tactile feedback facial prosthesis attachment device, minimal cardiopulmonary perfusion time, cardiac arrest time and blood product, ventilation time, ICU care requirement, incisional pain, length of hospitalization, and high quality repair, which include that greater than 95% repair and few pre-operative, less than 2%, and less than 1% more operative mortality. There is no SAM or residual leak. For the contraindication to MIS and robotic mitral valve surgery, there is an absolute and relative contraindication. Concerning the absolute contraindication, which include previous right thoracotomy and severe pulmonary dysfunction, MI or ischemia less than 30 days, coronary artery bypass required coronary artery surgery, severe generalized vascular disease, cerebral vascular disease, because this is of a concern during the peripheral cannulation, symptomatic CVA or stroke less than 30 days, aortic dysfunction, pulmonary hypertension, and significant aortic stenosis or insufficiency, severe mitral annular calcification, severe liver dysfunction, significant bleeding disorder, and dilated aortic root significantly. On the other hand, the relative contraindication, which include previous sternotomy, moderate pulmonary dysfunction, asymptomatic coronary disease, required PCI, limited peripheral vascular disease, asymptomatic CVA, or function less than percentage, moderate annular calcification, and chest deformity, including pectus or scoliosis. Regarding the evolution of minimally invasive mitral valve surgery, to perform the ideal cardiac valve, surgeon need to operate in a restricted area through a tiny incision, which necessitates assisted vision and advanced instrumentation. Although the ultimate goal of the completely endoscopic mitral valve repair has not been widely achieved, minimally invasive mitral valve surgery has continued to evolve. Many surgeons perform procedure along minimally invasive continuum, utilizing the variety of techniques, which include the limited incision or video assisted or video directed operation or robotic techniques. The term minimally invasive or limited access cardiac surgery has suggested reduce the size of the incision and avoidance of sternotomy and the use of partial sternotomy or mini thoracotomy or lack freedom for cardiopulmonary bypass. There is the level of assist in minimally invasive cardiac surgery, which is classified to 4 levels. Level 1 includes direct vision or limited incision from 10 to 12 centimeter, direct vision or video assisted 4 to 6 centimeter. Level 3, which includes the video directed or robotic assisted, which is micro incision 1.2 to 4 centimeter, robotic or computer manipulation, which is a bolt-like
This is now 1.2 centimeter. Now we'll talk about the incision and minimally invasive surgery. The type and size of musculoskeletal incision remain the central to discussion around the minimally invasive cardiac surgery. A mild or modified small stem or parastem and mini thoracotomy are used to access the cardiac valves. Although many surgeons prefer the hysterectomy approach, the right mini thoracotomy yield an excellent exposure for both direct vision and for videoscopic mitral valve access. So to access the left atrium for direct vision, using a limited access mini thoracotomy that's in 4 to 6 centimeter submedullary incision is placed along the anterior axillary line. The small section of pectoralis and intercostal muscle fiber are divided, and the thoracic is entered through the fourth intercostal space with minimal rib distraction. And this is the criteria for the ideal mitral valve repair through minimal invasive. The smaller 3 to 5 incision with minimal rib retraction can be used in video assisted, which is enough for prosthesis passage. Then minimal rib spreading to prevent intercostal nerve injury and use of intraoperative local anesthesia are the key to minimize the post-operative pain and discomfort. There is the figure A, which shows the hysterectomy and the mini thoracotomy in the left side. Here's the cross clamp. We'll talk about the transthoracic clamping in the right mini thoracotomy to video access. Most superior and transeptal mitral valve approach through a hysterectomy requiring a large incision. For typical mitral tricuspid operation, some surgeons use hysterectomy extended to the fourth intercostal space with direct aortic arch and right atrial cannulation. To access the mitral valve, they extend the atriotomy from the right atrium across the left atrial wall and continue caudally to divide into the interatrial septum. For the cannulation and the cardiopulmonary perfusion, all perfusion cannula are placed under endocardial guidance using Sandberg technique. Through 2 centimeter oblique groin incision, for all point over persisting suture and placed in both femoral visits near the inguinal ligament. The right femoral artery is cannulated, and for the inferior vena cava drainage, either 22 French or 23 femoral venous cannula is passed into the right atrium. De-airing, particularly cardiac de-airing, is particularly important in minimally invasive surgery because of difficult manipulation, and de-airing the cardiac apex cannot be difficult to be elevated. Also, with the right anterolateral mini thoracotomy, air tend to trap or retain dorsally oriented to the ventricular septum and in the right pulmonary veins. Moreover, this position placed the right coronary ostium in most vulnerable position for intraoperative failure. So we are using the CO2 particularly help in minimizing intracardiac air and should be begun before the cardiac chamber are open. Infusing CO2 4 to 5 liter per minute into the thorax and prior to cross clamp, release ventilate both vigorously and draw the gas deep into the pulmonary vein. After the atrial closure and following cross clamp, suction is applied to the aortic band. Constant transesophageal echocardiographic monitoring to ensure that the air is removed before being from the pulmonary bypass. Cross clamp aortic occlusion, we use the transthoracic cross clamp. Some surgeons are using the endovalve for the aortic occlusion. This is the transthoracic aortic clamp for minimally invasive surgery. And this is the endovalve. So regarding the right mini thoracotomy procedure, mainly the mitral valve, the indication, any mitral valve lesion, mitral stenosis or regurg, any tricuspid stenosis or regurg combined, some infective endocarditis cases, atrial fibrillation, ablation, all lesion can be finished through the same incision by the mitral surgery. Patient with secondary phase 3 or pre coronary sinus that is difficult to be done percutaneously, or if the patient prefers surgery. Contraindication: avoid inpatient with moderate to severe AI, as myocardial protection becomes challenging, resulting in severe RV failure. In a patient with fixed pulmonary hypertension or significantly high pulmonary pressure, patient with cardiogenic shock due to rupture of pulmonary muscle, patient with previous thoracic surgery or adhesion developed from the previous surgery, and a patient with severe perioperative management. The company can see that one of the most important things for the right thoracotomy is having the W with the tube, which will deflate one like during the bypass. The line surgical step must be in the left arm as you are doing the right thoracotomy. W with check position with endoscopy to deflate the right line. Central line, patient position 35 to 40 degree, right side up, and the right axillary axilla is free open. Filter bypass through small right groin incision. The cervical step, surgeon is starting with incising the pericardium. Then there is the quadriplegia insertion. Develop the endometrial groove before exposure to the mitral valve. Using the transthoracic. Exposure of the mitral valve. Coating technique, relaxing technique. Theme of Boston, the tiny incision. So concerning the complication and prevention, retrograde cardiopulmonary perfusion technique always induces the risk of lateral embolic stroke, vena-cava injury, and femoral arterial complication, and retrograde aortic. So care for perioperative vascular screening can minimize this problem. The whole cannula should be inserted using Sandokan technique and cardiography. Leg ischemia during retrograde perfusion can be avoided. We can place oxygen saturation monitoring badge and bottling, significant decrease in cannulated blood oxygen saturation. Place a shunt from the cardiopulmonary bypass arterial cannula into the distal femoral artery. Peritoneal injury can be caused by overstretching the pericardium or coronary thermal injury, ablation, or direct instrumental injury. It's a major problem in patients with compromised pulmonary function. Injury can be avoided by visualization of the nerve during instrumental insertion and coronary use. Overstretching can be avoided by making a pericardial incision at least 3 centimeters ventral to the nerve. Unilateral pulmonary edema is a serious complication. The short perfusion time, systemic cooling, avoiding barotrauma, limiting blood product transfusion, minimizing lung deflation time can reduce this risk. We also believe that low level positive pressure and frequent annual recruitment while cardiopulmonary bypass is beneficial. And the dysfunction is a serious problem and can be avoided or minimized by selecting patients with AF of no less than 40 to 50, systemic cooling, and making continuous de-airing and are mandatory to maximize myocardial protection. Ventricular distension is a serious problem and can be prevented by leaving the ventricular bed after repair or replacement. RV dysfunction can be minimized. Meticulous cardiac de-airing before we remove the bypass. And dirty chest elevation, place the RCA ostium in a perfect position for air embolism, for a residual left ventricular air or aortic trap during the birth. So regarding the clinical outcomes, a recent meta-analysis from the International Society of Minimally Invasive Cardiac Surgery showed that versus conventional sternotomy and minimal invasive had less post-operative air, chest tube drainage, transfusion, and infection. And there was no difference in repair quality or freedom from the reoperation. Moreover, the operative mortality was not statistically different, 4.5 with a conventional sternotomy versus 1.2 with MIS. Other benefits include reduced ICU time, less hospitalization, as well as faster return to the normal activity. These advantages were despite significant longer perfusion than the aortic cross-clamp time. On the other hand, they found there's more stroke with MIS 2 to 1.2 with a conventional, and aortic dissection 0.2 with MIS, and phrenic nerve injury about 3% in MIS group. So this is my reference. Dr. Hamad Al Habib is a minimal invasive cardiac surgeon in Kidfire Medical City, and our textbook Lawrence. Thank you so much.
الدرجة الأولى يا أخوان من هنا، أو الفرسان الذهبي والفضي، الضيافة على الجهة الثانية والهويات.
هوية. هذه ما.
Thank you, Dr. Hassan. If anyone have any questions? Thank you, Dr. Hassan, for your presentation. We'll have a break for 10 minutes, then we'll be back for the next lecture, inshallah.
Assalamu alaikum wa rahmatullah. Good afternoon, everyone. I'm just waiting for Dr. Hamad Al Habib to join us. You hear my voice and see my screen, guys?
Naranayat, yes, obvious.
I'm just waiting for Dr. Hamad.
Yes, go ahead, Ayat. I'm here.
Okay, so thank you, Dr. Hamad, for accepting the invitation with this, a really late notice. And also, I invited Dr. Haytham. You are there, Dr. Haytham?
يا هلا، بس بوجود إذا وجد الماء بطل التيمم. أستاذي وهذا دكتور حمد يعني الله يعطيه العافية.
Okay, so I'm gonna start. So today, inshallah, I'm gonna talk about aortic dissection. And to start with, these are my references. So I went through Oxford, Bojar, Johns Hopkins, and Lawrence, and multiple websites just to have a better understanding of the disease. Okay, so let me start with the story of this picture. So like when I was a third-year medical student, I was having a summer training in King Fahd Medical City, and I heard that an aortic dissection case is coming. So I was just interested to see what's going on. And then when they brought the patient from emergency directly, they canceled the case, and then directly they brought this aortic dissection. He was really, screaming, shouting when we started transferring him from the bed to the table. So it was really, it affected me emotionally. He was just 32 years old, and he was married, he had children. And somebody told him, I think one of his friends told him that just stop your antihypertension medication. Stop it, and I'm gonna give you Herpol so you can control your hypertension. And then he got aortic dissection. So I was thinking, what can I do for the society to prevent this fatal disease? So when I was an intern, I conducted a campaign awareness about this disease. And Dr. Huda, Dr. Hawaida, they were supervising me. And it was really amazing. Over 2 days, many people came in Hayat Mall, and they were like surprised that there is something called aortic dissection, a fatal disease, but can be prevented with simple measures. Okay, so as an introduction, aortic dissection is the most common fatal disease process of the aorta. It falls under the category of acute aortic syndrome, and then can be easily misdiagnosed. So you have to have a high suspicion. So 30% of the patients are misdiagnosed initially when they have chest pain. So you will go for other diagnosis, and then you will discover later that the patient is having aortic dissection. The incidence of acute aortic dissection is 2.6 to 3.5 per 100,000 persons. It's like roughly twice as common among men than women. And then typically men present in their late 40s, 60s, and females, they present in their 70s. Women present more frequently late in the disease process with hypotension and tamponade. So yes, they present in their 70s, but also with a more complicated disease. Mortality rate is 1 to 2% per hour if this disease is not treated. And then intramural hematoma, penetrating aortic ulcer tend to occur in older patients and more often affect the descending than the ascending. So I'm talking about intramural hematoma and penetrating aortic ulcer just to keep in mind the underlying causes of dissection, and then I'm going to talk about the differences. Acute aortic syndrome occur more frequently in the winter months than summer months, and more often in the morning than evening, as per Johns Hopkins book. Okay, so now etiology and risk factors. We can classify the risk factors or the etiology behind this disease into 3 categories: congenital, acquired, or iatrogenic and traumatic. So the age, up to 90% of patients, they are more than 60 years of age. Smoking, long-standing hypertension in 75%. Also, when you have a high cardiac output status, like in a pregnancy, Also connective tissue disorders like Ehlers-Danlos and Marfan and Turner. And then mutation in some genes like, for example, TGF-beta or smooth muscle cell actin, when they have a mutation, patients tend to have aortic dissection. Atherosclerosis also is a risk factor, but only in a pre-existing aneurysm or in atherosclerotic ulceration. So it will not happen unless there is a pathology behind it. Bicuspid aortic valve, cystic medial degeneration, aortitis, competitive weightlifting. And regarding iatrogenic aortic traumatic, we have motor vehicle accidents and some procedures that lead to dissection. So who can elaborate more about the iatrogenic causes? What a procedure we can do, we do that causes aortic dissection? Anyone? Hello? What procedures we do that causes aortic dissection, put the patient at risk of aortic dissection? Abdullah, you are there? Let me see who is there. Yeah, we can say Faisal Ghamdi. Okay, Ahmed Sulbud. Okay, so when we do aortic cannulation, for example, and then when we do a cath and we cannulate for a peripheral also bypass, those are the most common things, iatrogenic things that we do and causes aortic dissection. This is what's in my mind. Dr. Haytham, anything else?
All cardiac procedure, aortic dissection as iatrogenic from any procedure, even when they did a cath for any patients, that can lead to aortic, can lead in any instrumentation in the aorta can lead to the aortic dissection. In general, one of it when you perform your cannulation, this is the famous and not common example, and a famous common example. Yes. But any instrumentation that can lead to aortic dissection as a complication.
Okay. Thank you. So then let us move to pathophysiology. So pathophysiology is not well understood, but we have several hypotheses. So when I went through Lawrence and Johns Hopkins, I saw some hypotheses early and later when they discovered how the disease happened. So early cystic medial degeneration, where the media is abnormal, means histologically there is a elastin fragmentation, smooth muscle cell loss, and deposition of ground substance. And this will increase the wall stiffness and diminish the elasticity. So they said maybe this is the cause. And then when they saw that few patients only have this, they forget about it. Later on, they said maybe the atherosclerotic ulceration that penetrates the media, it might be the source of the intimal tear. But again, it's uncommon. So at the site of the intimal tear, so they said maybe there is something else. Finally, they said that they saw that in 10 to 20% of the patient, there is an intramural hematoma that results in bleeding of the vasa vasorum into the media. It's thought to be to cause this aortic dissection because of sufficient stress that causes this tear. So they noticed that in multiple CT that was done for the patient to diagnose a chest pain in early stages, it was approved that there was an intramural hematoma. Sorry, guys, my computer is hanging. Just a minute. Can somebody help me?
Close it, each computer.
And the share screen and reopen it again.
Yeah, I'm trying to unshare or close. It's not doing it at all.
I will do it now for you. Just 1 second.
Okay.
Try now.
You see my slides?
Yes.
Okay. And then, so if the blood leaves the aortic lumen via an intimal tear, separating the inner from the outer layers of the media, it creates a false lumen. During diastole, the dissected channel that was created can extend proximally or distally, potentially causing a branch artery compromise or rupture as the outer wall gets weak. So sometimes the patient with a chronic dissection, they will be having aneurysms that might expand and causes pain and so on. It might be asymptomatic also, and they might need a surgery. So it might lead to an aneurysm. Primary failure of the aortic wall occurs when the mechanical forces exceeded the mechanical properties. So then structural failure occur when the wall stress, which is a product of aortic diameter and blood pressure, exceeded the wall strength. As you see in this picture, in the right side, you have an intimal tear that causes a bleeding. You have a false and a true lumen, and you have an intimal tear that causes bleeding. In the left side, we have a true and false lumen. And in this case, you see that the true lumen is compressed by the false lumen. So it's causing malperfusion to the patient. So also those are under the hypothesis of the disease. Now moving to the classification. So we have Stanford and DeBakey classification. For Stanford, we have type A and type B. So whenever something is involving the ascending aorta, so it's type A. For type B, anything that is not involving the ascending aorta. But for DeBakey, we have multiple. So we have type 1, type 2, type 3A, and type 3P. For type A, type 1, sorry, it's a tear in the ascending aorta that extend into the arch. For type 2, it's only limited to the ascending aorta, as you see in this as you see in this picture. And then we have 3A. 3A, it's a tear in the descending that is limited into the descending itself. But for 3B, it's the descending that might extend into the arch and ascending. So DeBakey type 1 and type 2, it equals Stanford type A, and then 3A and 3B equals Stanford type B. This is a table that I've taken from Oxford. So apart from Stanford and DeBakey classifications, we have also classification that depends on the timing of the dissection. So acute dissection, patients present within 14 days. Chronic, when the patient present after 2 months. And then we have subacute between 14 days and 2 months. Now moving to the presentation of the disease. So it's different in type A and type B aortic dissection. The site of the pain, how the patient presents, and so on. So for type A, it's life-threatening condition. 30 to 40% will die immediately. 20% of the patient, they die before reaching even the hospital. And then this type A must be considered in any patient presenting to ER with an acute onset of chest pain, and it's misdiagnosed in up to 40% of patients. So the classical presentation of type A, it's tearing chest pain that radiates to the back between scapula, but this has been found to be less common than the non-radiating sharp chest pain, according to International Registry of Acute Aortic Dissections. Invariably acute pain in onset and severe in nature, usually the worst pain the patient had ever experienced, and also it may wax and wane. For type B, it's usually back pain that might radiate into the abdomen. Generally, it doesn't cause anterior chest wall pain, but it's more with type A. And then potential rupture into the mediastinum, pleural spaces, or abdomen may occur. And malperfusion from branch artery compromise from the descending thoracic and abdominal aorta may occur. And also paraplegia developing 2 to 5% as a result of spinal artery occlusion. So if the patient is having malperfusion, either to the brain or abdomen, mesenteric or something, you have to sometimes to change your approach. But for the malperfusion to the brain, then patient will be having stroke. And even if you try to perfuse the area and you operate on a patient, still they will suffer from stroke. So it's not the the final solution for the problem. So keep in mind that chest pain in acute aortic dissection is the most common presentation. It's 79% in ascending and 63% is in descending aortic dissections. Arch fizzles occlusion causes stroke in 5%, MI in 20% of patients, and hemopericardium can occur in 1/4 of type A dissections, which is the most common cause of death. Severe AI can occur in about 1/3 of type A dissections, and occlusion of fizzles may lead to upper and lower limb mesenteric renal ischemia. So you have to do a peripheral vascular examination, which is abnormal in 20% of the patients. Rarely acute aortic dissection may cause SVC syndrome, hemoptysis, or airway compression, for example. Also, aortic dissection might be painless in 6.4% to 17% of patients, and some data from IRAD, they suggest that the mortality rate is higher than the one than the patient that presents with typical presentation. This painless presentation usually associated with aneurysm. It might be presented with symptoms of malperfusion of a brain or other organs, and we have mentioned that even if you operate, they will not improve, for example, from stroke point of view. So stroke is a presenting feature of 5% of patients with acute aortic dissection. And malperfusion is not common with the chronic aortic dissection. Why? Why we are saying that malperfusion is not common? What do you think, guys? Abdul Malik, what do you think? Okay, Mohammed Al-Aboud. Okay, Soha. Any idea, Soha? طيب خليفة. Okay, so malperfusion is not common with the chronic aortic dissection. What I've read from Lawrence that we have a communication between the true and false lumen. So they will not present usually with a malperfusion because of this communication between the lumens. Am I right, Dr. Haytham or Dr. Hamid? Okay, I'm gonna continue. This is a table that I've taken from Lawrence. The data here about the frequency, the gender, the age, hypertension, and other pain and type of pain, and then the other presentations. How frequent they are in type A and type B. So for type A, it's 60 to 75%, and type B, it's 25 to 40. Males are more common than females, and the age we have talked about. Regarding the pain is retrosternal for type A, and it's interscapular usually with type B. And then you have the other signs and symptoms, and you have the peripheral pulse deficit, which is upper in type A. It's more common with upper and lower also. And then type B, it's lower extremities. Here's a table also from Lawrence that shows the frequency and location of malperfusion in type A and type B. So you have for renal, it's 23 to 75% they will be having a dissection, and then the extremities, 25 to 60, and then we have the mesenteric, coronary, cerebral, and spinal. How we diagnose the disease? So first of all, take a full history. And I don't mean that you have to take a full history, that you spend time in ER talking to the patient while he's shouting and unstable and cannot tolerate staying in ER even. So it depends on the situation of the patient. If he is in acute or chronic or referred to you or something. So sometimes when you are in emergency situation, then you will take just the important information that you need. For example, the risk factors in the patient or the family, and then the character of the pain itself, for example. So keep in mind that chronic aortic dissection might be difficult to be distinguished from an acute one, especially that patient with a chronic aortic dissection have pain from other causes also. And recurrent chest or back pain usually indicates extension, expansion, or rupture of the dissected flaps. So here's a picture of a huge aneurysm that was operated in our hospital. And when the surgeon opened this aneurysm, he saw some dissected flaps, and he was like asking, I don't know whether this is an acute or a chronic one. So sometimes you will reach the point of operating on a patient, and you don't know if this dissection or dissected flaps are an acute situation or chronic situation. Again, it's hanging. Okay, I'm trying to, okay. So when you examine, you will find that the patient might be hyper or hypotensive. You have to examine the patient's pulses carefully, examine carotids and femoral.
Yes, the slides are not.
The slides are not showing.
I stopped the shared screen by you just to share the again.
Just a minute, طيب. So we reached this picture, right? You heard me.
Yes, at this picture now.
Okay, so we are gonna go to examination, maybe, yes. So when you examine the patient, you might see him hypo or hypertensive. When you examine the patient, also examine the pulses carefully, look for the carotids and femoral, and then differential upper extremity blood pressures is a strong clue in young patients mainly. And then examine the cardiac system, check for AI murmur, and which is usually present in acute dissection. And don't forget to examine the respiratory system. So you might find, for example, absent breath sounds. You will suspect that the patient is having, for example, hemothorax or pleural effusion or something. And then neurological examination is essential in 40% of the patients. And evidence of renal dysfunction, bowel ischemia may necessitate modification of your surgical approach, as we mentioned earlier. I don't know why my computer is getting crazy now.
I will stop the share and share again, okay?
Sorry for that, Abdul Malik.
I had to try to just make without slide share, just opening the PowerPoint and
okay.
Make it big without slide share. Try this.
Okay. Let's see, Zoom does. So it's clear, it's okay now?
Yes, you can continue like that, no problem.
Okay. And then investigate. So you do a chest X-ray. It might be normal in 10 to 15% of patients with type A aortic dissection, and it's abnormal in 60 to 90% of patients in acute aortic dissection also. So you see in this chest X-ray, there is a deviated trachea, there is a double control aortic knob, and then you might see also a widened mediastinum, and you might see also a left pleural effusion. So why we have left pleural effusion in aortic dissection? What do you think, guys? Abdullah. Abdullah?
Yes, Ayat. Why we have the left pleural effusion? Well, the aorta goes, the dissection is extending. It will leak in the pleural, in the pleural cavity. Well, it's somehow wrapped around the pleura.
Okay. So what I've read, it was like from Lawrence, there is an inflammation process during the aortic dissection, and this causes a pleural effusion. So any other opinion other than what I've said or Abdullah mentioned? Dr. Haytham, Dr. Hamad, any comments?
This is one. The other one, this is one. The other one, especially with the type B, if you see a huge hemothorax, for example, that means leaking or bleeding. Open, sometimes it opens, then it will seal again. And there is opening, then there is a sealed or bending perforation. Especially this can happen with both type actually.
Okay. And in this X-ray, you can see that there is a shadow here. It has inlet and outlet, and it's like it's having wavy margins. So this is also one sign on chest X-ray. And then ECG. So IRIDE data showed that 33% of patients with type A dissections had a normal ECG, and non-specific ST changes were noted in about 40% of patients, and about 11% of patients had ischemic changes. Why? Because of the involvement of coronary ostia. So they will be having ischemic changes. Also, you might find LVH on ECG because of long-standing hypertension. CT scan is the one we are using to diagnose an aortic dissection. So it's 90% sensitive and specific in identifying intimal flaps and differential flow into true and false lumens. CT scanning, especially 3D reconstruction, can provide beautiful images of aortic dissection and the involvement of the branches. The presence of pleural or pericardial effusion suggests acute process on CT. So as you see here, we have a false lumen and we have a true lumen. So the false lumen is usually the bigger one, and it's compressing the true lumen. This is a 3D image with, you can see the dissection in the descending. Abdominal, sorry. And then we have some signs on CT also that guide us that there is a dissection or a flap. So we have the peak sign. It will tell you that the lumen is the false lumen. And then we have a Mercedes-Benz sign. It means that there is a dissected flap. And I have a question: how to differentiate a flap from an artifact on CT? Anyone?
To follow it on the CT scan, and also with dissection, usually the diameter will be bigger.
Okay, so the artifact is the opposite of what Abdullah mentioned. Thank you, Abdullah. And then how to differentiate aortic dissection from an intramural hematoma. So as you see here, there is sometimes a completely thrombosed lumen that will tell you that this is a false lumen other than being an intramural hematoma. And sometimes you see calcium that is pushing. So this calcium means that there is an acute process going on, acute dissection on CT. Okay, then we move to echo. We have transthoracic versus transesophageal. So transthoracic, yes, it will show the flap and so on, but it's not sensitive as the transesophageal. So transesophageal will show you the flap, it will show you how it moves with the heart contraction, and then it will show some, if there is any ischemic changes or something, if there is ostial involvement, and it will show the function of the heart. But still, okay, when I'm gonna take the patient to OR, I need transesophageal echo to assess also if there is any AI, but it's not the first modality to start with. So CT is the one. And then we have MRI. MRI is the most sensitive and specific, but it has its own limitation, timing, and if the patient is unstable and so on. So we don't do usually MRI. And then we have coronary angio and aortography. So coronary angio, what I read from Johns Hopkins, that sometimes they take the patient for stent graft placement, and that's why they take the patient to cath lab. But it's not the one to start with, and it depends on the patient's situation, acute, chronic dissection, age of the patient, and if the patient is stable or and so. So it's the same as in Lawrence. And then the aortography also, it was the gold standard because it visualized the, the aortic arch and so on, but it's no more. So aortography needs also nephrotoxic contrast, and I don't need it since I have a CT and everything is visualized well. This is a table from Oxford that differentiate the sensitivity, specificity for each modality. So for TEE, yes, it's widely available, familiar. You see the dynamic image, how it moves and so on. So it shows you the coronary ostia, the LV function, AI, the pericardium, the pleura. For CT, it shows you also those details about pericardium and pleura, and also head and neck fizzles. And it might need of course, we need a contrast in this. For MRI, it is the gold standard. It shows you many details, but it's not easily available or accessible. For aortography, as I said, it was until recently gold standard, but so it facilitates and facilities and expertise. It's not widely available. It needs arterial access, and it's often difficult and can precipitate rupture. It shows also the perfusion of true and false lumen and the flap itself and the AI, but it's not widely used, and it's not as easy as the CT. But what I've heard from some seniors that they told me that it's contraindicated to take the patient to cath, since you can see that there is a dissected flaps. So you don't take the patient for cath. So what is your comment, guys, regarding this? If there is a flap, then I cannot take the patient for angio.
What will the angio add if I know that the patient has dissection?
No, the angio.
Thank you.
Yeah, the angio.
No, I think Ayat is alluding to not acute dissection, to subacute, or lead presenting. Of course, acute type A is a different call. I think subacute or even chronic, when such discovered later on, and to investigate the coronaries or the question at the age and at the comorbidities that the coronary pathology is likely.
Yes.
Will you take the patient to coronary angio or no? Can you answer this, Faisal?
I think if the flap is near the aortic root and there is a possibility of it affecting the coronary ostia, I would do it if the patient is stable enough with before the OR, because he will need CABG with the aortic dissection repair.
And this is what I've read, but what I've heard is something different. So that's why I'm asking. Any input from the seniors? Because it's still an invasive procedure, and the patient is having a dissected flap.
Probably, I think it's an individualized, decision. It's very risky for some retrograde dissection, extension for any kind of dissection, putting catheters here and there.
Yes.
But I think it's it depends, individualized decision, multidisciplinary with the interventional cardiologist, and it has its own risks and benefits. And maybe a good CT gated CT coronary will help to substitute the coronary cath in such cases, with the risk of making the case worse with the catheterization.
Yes. Any comment, Dr. Hamad or Dr. Farid, regarding this?
I want to keep going. We'll talk about this because it will take a bit of more explanation.
Okay.
So finish and then we'll talk about it at the end.
Okay, sure. Okay, then this is echo, transesophageal echo. So you see the dissected flap here in the long axis, and here also in the short axis. And this is an MRI. Also, you can see the dissected flap here. It's extending, I think, up to down there. And then also I have a picture here for MRI also, but it's a penetrating aortic ulcer that causes the dissection. And then I have a picture for aortogram. It's acute P dissection with a flap here. So they give a nephrotoxic, usually it's a nephrotoxic contrast, and they show the arch and the great vessels and so on. So it was the gold standard, but it's not more. It's no more the gold standard. The gold standard for I mean it's not the first to go with. And then I have a slide for blood tests. So it's not specific, and it will not tell you if the patient is having aortic dissection or not, but you might find some changes. So leukocytosis is not that much. It's mild to moderate. So it's not that much. Anemia, if you have if there is a bleeding or something. And then you have high troponin if there is osteal involvement. You have high LFT, creatinine, lactic acid in chronic hypoperfusion. And then you have high D-dimer, also in acute dissection, but it's not specific. And then we have smooth muscle myosin heavy chain protein that is released from the damaged aortic medial smooth muscle, which is not all the time you will do it. The management, I think my colleague is going to talk about this, but I will just highlight the things. So you have to strictly manage the pain because it will increase the blood pressure, and you don't want this. And then blood pressure control. We have medical for type B. We have a surgical, of course, for acute type A. And then we have the endovascular also. You have to follow the patient, lifelong follow-up. And for pre-op considerations, you have to reduce the blood pressure to about 110 to 120 mmHg systolic, and then the heart rate to be 60 to 70 beats per minute. The patient should be carefully monitored and must undergo diagnostic testing as soon as possible to establish or exclude the diagnosis, so you can take the patient, for example, to surgery. And then there are some antihypertension medications that are preferred in this case. So beta blockers, esmolol, metoprolol, labetalol, and you can add also sodium nitroprusside as a vasodilator if you want. And then you aggressively manage the patient up to the time of surgery. It's essential to prevent rupture. The last slide I have is about the outcome and the prognosis. So the in-hospital mortality rate associated with surgical repair of type A is approximately 25%. For medically treated type B, it's closer to 10%. And then the late outcomes for each one I'm going to talk about. So in first and fifth and 10th and then 15 years, it's for type A, it's being 67, 55, 37, and 24% respectively. And then patients with type B dissections has survival of 56, 48, 29, and 11% respectively for those years. And thank you for your attention. Any comments, any questions? Any comment, Dr. Hamad?
Yes, Anna, thank you very much for this thorough review. Yeah, now, regarding your point about doing a coronary angiogram or CT coronary angiogram for diagnosing coronary artery disease, of course, it is contraindicated both in acute and chronic to do a coronary diagnostic coronary angiogram for any patient with suspected type A aortic dissection. Okay. Having said that, most of the patients, they will not die of coronary artery disease. The most important thing you take them to are diagnosing coronary artery disease pre-type A aortic dissection. We rarely do it, and there's a lot of retrospective data analysis, especially from Cleveland Clinic. It showed that long-term follow-up of patients with type A dissection, they did not die of coronary artery disease, rather they died of aortic disease. And let's say we're doing someone elderly and he's not coming off pump, ST changes. At that time, At that time, then you can consider blind bypasses with vein grafts mainly to LAD or
Can you mute your mics? I cannot hear Dr. Hamad. Okay, Dr. Fadal.
In terms of if it happened post-op in the ICU, ST changes, it depends what kind of a procedure was done. For example, if it's a Brental procedure, then coronary button anastomosis, stenosis or kink or any technical factors has to be considered early. And if you have the luxury of having time patient stable, you can take him to a CT or angio suite to do diagnostic coronary angiogram. But keep in mind that most of the patients, they will not have or they will not die of coronary complication. They would rather die of aortic complication. So it is really important not to delay the management.
Yes. Dr. Haytham, you have any comment?
No comment.
Okay. And then we're back to that patient that I've told you in the beginning of my lecture. He survived and he had some ICU psychosis post-op, and then he got fine, and then he improved. We already, that time we transferred him to the ward and he was fine. And then when he saw me, he told me he had ICU psychosis and I was taking care of him in the ICU. But when he saw me, he told me, "You are Dr. Ayat." So I was like happy he survived, for his children at least. So thank you guys. So we can prevent this disease. It's a fatal disease, but we can prevent it. Thank you for your attention.
Ayat, we cannot prevent this disease. This disease will continue. The only treatment of this disease is gene therapy. We can treat this disease by having a dedicated team, early diagnosis, faster transfer to the operating room, no delay, a good plan preoperative, a good technical plan intraoperative, and excellent care post-op. This disease cannot be prevented. This disease is a genetic disease. It will continue unless we do gene therapy. Identifying the patient at risk of developing type A aortic dissection. This is our duty as physician surgeons to develop either a community directed programs or a collaboration between aortic surgeon, vascular surgeon, pediatrician, genetic physicians, and family medicine or family physicians. This collaboration should aim identifying people at risk. For example, if a family physician see a young man who's very tall and has features of Marfan syndrome that is undiagnosed. So this is what I'm talking about, is early diagnosis. To prevent it, it's very difficult. So this is the aim, that we early diagnose people at risk and treat them early. Okay. Even in US or Canada, during our training, we still see some patients who are admitted with type A dissection who are the first time diagnosed with Marfan syndrome. So even it happens in the West. It's not just us. But it's really unfortunate that all the dissection I have done, especially in Marfan's, none of them is diagnosed preoperatively. And most of them, I would say 90% of them, they have seen already an ophthalmologist for a lens dislocation or whatever, this non-complication of Marfan. They have seen a spine surgeon for scoliosis, etc. So once the Marfan is triggered, the system that must be developed, it trigger the database, enter to Ministry of Health, and this patient should be directed toward the right channels for early diagnosis and early treatment and good follow-up.
Yeah, but I meant at least for hypertensive patients and patients who, motor vehicle accidents. We have here lots of cases. So I meant at least those, yani.
Yeah, even those. I mean, yeah, you can prevent it by educating the community, seat belt, and etc. Still, motor vehicle, it will give you most likely a transection rather than a dissection. In terms of our hypertensive patients, So those are very difficult to treat. They come in old ages, and it's very difficult to pick up. They usually, of course, treating hypertension, etc., would decrease the risk of dissection. But once they're at risk of dissection, the only thing that you can do to prevent it is to get serial echoes and CT to follow their aortic dimensions. And any patient more than 5.5 centimeter who are at risk and good candidate should go for prophylactic replacement of his ascending aorta. So I really would love to live in a day where I can prevent type A aortic dissection, but it's still way to go to prevent that disease.
Inshallah, we can in future. Thank you, Doctor, for your comment. Dr. Claudio, any comments from your side? Okay, then. With this, I conclude my lecture. Thank you so much, guys.
Thank you, Dr. Ayat. Thank you, Dr. Ahmed. So we'll take a break for 5 minutes, then we'll start the next lecture, inshallah. Thank you.
Hello.
يا عبد الملك ماني قادر اسوي فول سكرين بعدين اسوي بعدها سكرول داون، ما قدرت. يعني اقدر على الوضع هذا بس.
البرزنتيشن واضحة عندكم شباب؟
اي موجود واضح.
يعطيك العافية سلطان. يلا we can start.
Yes, you can.
بسم الله الرحمن الرحيم. I couldn't maximize the screen. So I hope this is fine. Is it clear?
ما تقدر تسوي الفول سكرين اللي تحت.
Once I did this, I couldn't scroll down anymore. I don't know why. Let's try for the last time. Yes, now it's fine. Okay, we can start.
Yes.
Okay, this is Abdullah Al-Qahtani, cardiac surgery resident, R4 from King Khalid University Hospital. Today, I have the pleasure to introduce or to present this aortic dissection, an extension of Dr. Ayat lecture, indications and management. So this is the introduction. Treatment choice depends on its location and duration. It's about 66% of all dissections present in the acute phase. Regarding the Stanford type A ascending aortic dissection, surgical management is superior to medical management. For uncomplicated Stanford type B, which is the distal aortic part, dissections including abdominal aortic dissections, medical management is preferred over surgical. So complicated Stanford type B aortic dissections require surgical intervention after medical therapy is initiated, which is I'm gonna discuss this in the next slides, inshallah. So the classifications, as everybody knows, I think Dr. Ayat explained this. We have two classifications, Stanford and the DeBakey classification, as you see here, type A, type B. Type A, which is confined, type 1 DeBakey, which is whole aortic structures from ascending arch and descending to up to the bifurcation. Type 2, it's confined to the ascending aorta up to the brachiocephalic. 3A, 3B, which is in the thoracic aorta, A, confined to the thoracic, B, to the thoracic and abdominal aorta beyond the renal arteries. So management in general, ICU admission in a tertiary center, immediate cardiac surgery consultations, a close observation of the blood pressure, urine output, and neurologic status. A prompt blood pressure control is critical, can reduce the propagation of dissection. So the generally presents as a hypertensive emergency. Prime considerations of medical management is to decrease the shear stress in the aortic wall by decreasing blood pressure and the heart rate. Long-term blood pressure control is required for every patient who has experienced aortic dissection. So main goals of medical management is systolic blood pressure between 100 to 120 and 60 to 70 millimeter mercury diastolic, pain-free by intravenous opiates, and minimize shear stress by beta blocked to 60 per minute heart rate. So antihypertensive of choice starts with beta blockers. Use of a vasodilator in isolation will actually increase aortic shear stress by widening the pulse pressure and the pressure of the left ventricular ejection. So surgical management, as we mentioned before, type A dissection is the must indicated for surgery. The aim of surgery in this case is to prevent the life-threatening complication of acute type A dissection, which include intrapericardial rupture with tamponade, myocardial ischemia, or acute aortic regurg. Resect the site of the primary, this is the general principles, resect the site of primary intimal tear to prevent proximal and distal extension of the dissection. Restore flow to the true lumen, replace those portions of the aorta most prone to aneurysmal dilatation and rupture, restore aortic valve competency. Operative technique. First of all, we have to monitor ECG, pulse oximetry, 2 arterial monitoring lines, CVB, as well as Swan-Ganz catheter, nasopharyngeal and bladder temperatures, TE, cerebral oximetry to monitor cerebral oxygenation, and cerebral activity by EEG, which I couldn't involve here in the slides. So operative technique, cannulation strategies. The most important thing is to get the patient well perfused, either a femoral artery, right axillary artery, aortic cannulation with the Seldinger technique. So operative technique, cannulation strategies depends on the hemodynamic stability, extent of dissection, whether or not potential cannulation site is involved, which is I'm going to talk about in details now. We'll start with femoral artery cannulation, which is rapid, easy, used to unstable patients. However, there is some risk of retrograde embolization and malperfusion. Axillary artery cannulation, uncommonly affected by dissection or atherosclerosis, allows for antegrade cerebral perfusion. So it's 2 benefits. Time consuming, especially in obese patients. Brachial plexus injury. If you are using axillary artery cannulation, you should have a contralateral, radial artery or femoral artery line, because the pressure on the ipsilateral arm is falsely elevated. Okay. So this is some pictures just to explain what I'm talking about. This is the site of incision in the left picture to approach the axillary artery for cannulation. And this is especially about the Dacron patch, Dacron grafts, sorry, and the clamp. If you can see the pectoralis major muscle, axillary vein, and superiorly the axillary artery, which you can extend with Dacron graft for to make your bypass easier. So operative technique also, incision, venous cannulation, and preparation of the bypass. Sorry guys, I think I have to recharge my, no, it's fine. Okay. Operative technique, so incision, venous cannulation, and preparation for bypass, midline sternotomy, opening of the pericardium, single, double stage, right arterial cannula, retrograde cardioplegia cannula, and venting through right superior pulmonary vein. We have an important part, which is cerebral protection as well. Surgical repair of aortic dissection requires interruption of blood flow to the brain during the period of circulatory arrest. So the deep hypothermic circulatory arrest may be effective for a short period of time, not exceeding 60 minutes at 18 temperature centigrade. Continued cerebral perfusion during the circulatory arrest time is alternative, especially over 20 minutes, and can be given either retrograde or antegrade. So the retrograde cerebral perfusion, which is through superior vena cava, needs to be cannulated. Flow, it's from 500 to 700 ml per minute to avoid cerebral edema, facilitates the uniform brain cooling, flush air and deprive out of the cerebral circulation. The second part is the antegrade cerebral perfusion, or the second type of the perfusion, provides adequate nutritive delivery, requires right axillary cannulation with clamping of the innominate artery, bilateral antegrade with cannulation of both innominate and left carotid arteries. The bilateral allows to extend periods of hypothermic circulatory arrest with excellence in neurocerebral protection. Retrograde flow through the left common carotid and increase the left-sided brain oximetry are suggestive of adequate blood flow in both hemispheres. So as you see here, this is a gross picture of intra-op ascending aortic dissection before the procedure. As you see, after the intimal dissected, and goes to the ascending aorta, you can see the clot with the competent aortic valve. So location of the primary intimal tear. Once the aortic cross clamp is applied, the ascending aorta is opened proximal to the cross clamp to locate the primary intimal tear. Okay. So the initial incision is into the false lumen. Any clots that is present is removed from the false lumen, exposing the intimal tear. The aorta is trimmed circumferentially, approximate 5 millimeters distal to the peaks of the aortic valve commissures. The aortic valve and coronary ostia are carefully inspected. If the coronary ostia are not compromised by the dissection, which is good, handheld cardioplegic catheter may be used to deliver the cardioplegia through the ostial main coronaries. Surgical options for type A aortic dissection: ascending aorta interposition graft, and aortic valve replacement. I think this is a Bentall procedure. Ascending aortic interposition graft and resuspension of aortic valve, 85%. Aortic root replacement, valve sparing, aortic root replacement, hemi-arch or total arch replacement. So management of the aortic root. A woven Dacron graft is selected for ascending aortic replacement because the Sanjet is approximate 10 to 15% smaller than the aortic annulus. So the graft size selected is typically one size smaller than the aortic annulus in order to promote central cohabitation of the aortic cusps, as you see here in this picture. So this is a real life picture. If the dissection flap has detached one or more commissures, they can be resuspended by using pledgeted double-armed polypropylene sutures or double-loaded, placed across each detached commissure and through the outer layer of the aorta. So indications for aortic root replacement: severe damage to the sinus by dissection, which involve the sinus of Valsalva all around, tear extending to the sinus, connective tissue disease, root aneurysms. Sealing and reinforcements of the dissected aorta. So this is the operative technique, surgical technique. Resect tear, declot and dry the false lumen. Place sponge in the true lumen. Use Teflon felt, which is I will explain the next picture to make it clear for the viewers. Use Teflon felt to create a new media and inject little glue within the false lumen, compressing it as you progress. Use another Teflon felt on the outer wall of the aorta. So the graft to the reinforced aorta, and after completing the posterior layer, use another Teflon to reinforce the aortic wall posteriorly, then complete the anterior layer. Apply BioGlue externally to the aorta. As you see here, the BioGlue used to obliterate the false lumen. So, and the lower picture, the Teflon, how to use inside and outside the aortic root just to reinforce the thickness. Okay, if the dissection involves the coronary ostia, okay, we have minimal repair with interrupted stitches, okay. The other part is extensive, which needs repair of the button with Teflon or pericardium prior to implantation. If the button cannot be repaired or the dissection extends into the proximal coronary, perform a capro repair with either 8 mm Dacron or vein graft. If the button and the proximal coronary can be salvaged, perform a CABG. As you see here, this is the before the reimplantation of the coronary main coronary arteries, which is intact in this picture. This is the up view for this procedure after reimplantation of the coronaries on either sides. So this is the last view, which is this is the surgery done in King Khalid University Hospital in aortic dissection patients with reimplantation of the main coronaries. So this is a study about outcomes of surgical treatment of acute aortic dissection, which was applied on 4,400 patients Almost more than 50% of these patients are type A. Mean age was 61 years old. 68 was male, unfortunately, of course. Conventional repair, 19.7 hospital mortality. Patients with aortic dissection at young age, less than 40 years, are less likely to have hypertension and more likely to have Marfan, bicuspid aortic valve, or pregnancy, which is secondary hypertensive causes. Or maybe it's the tissue itself is diseased, like in Marfan syndrome. Other study, which is the outcome of surgical treatment of acute aortic dissection, which is abbreviated by GIRADA. Yes, 2,100 patients from 2006 to 2010. All are type A, 30% 70 years old, 16.9% 30-day mortality, which is less than previous study. 9.5% new post-operative neurological dysfunction, age, coma, CPR, malperfusion, and a long OR time were significant risk factor for early mortality as well. So, yes, independent predictors of in-hospital mortality: age more than 70 years, previous cardiac surgery, hypotension or shock, cardiac tamponading, malperfusion syndrome of visceral vessels, ischemia or infarction by ECG. Key message: many aortas that dissect are smaller than the current cutoffs for surgical intervention, 5 to 5.5 centimeters. This argues for better genetics, biomarkers, and imaging studies to currently identify patients as at risk, as Dr. Hamad mentioned. ECG and chest X-rays of a little help for early diagnosis. D-dimer is sensitive, but it's not specific for early diagnosis. Type A early mortality is declining despite operative on older high-risk patients. So this is key message for type B TVAR is replacing surgery for complicated diseases. The aortic arch remains halfway between A and B, and it's optimal. This is a gray area, and it's optimal management. Therefore, it's an area of continued uncertainty. So primary indications for extended arch replacement in acute type A aortic dissection. Aortic tear originates in aortic arch, aneurysmal enlargements of the aortic arch, extensive dissection involving the brachiocephalic arteries, younger patients with connective tissue disorders. So no conclusive data to indicate that extended arch replacement reduces the frequency of subsequent distal aortic operations or improve long-term survival. If the arch intima is intact, if the arch intima is disrupted extensively at the lesser curvature, if the arch intima is disrupted at the greater curvature. So let's take it one by one. If the arch intima is intact, ascending hemiarch with open distal anastomosis under circulatory arrest. If the arch intima is disrupted extensively, so we excess as much of the optimal tear, obliterate the false lumen, then ascending hemiarch with open distal anastomosis. Last, if the arch intima is disrupted at the greater curvature, total arch replacement, usually with individual great vessel implantation. So type A, dissections post-operative care. No sedation until the patient awakes up. Serial lactate, liver function tests must be followed up. CBC, coagulation profile, creatine kinase to assess rhabdomyolysis. Type A dissections follow-up. Before hospital discharge, CT scan or MRI should be applied. Initial evaluation after discharge, CT scan or MRI at 3, 6, and 12 months. Re-image aorta every 6 to 12 months thereafter, after the first year. Control of blood pressure, this is the main and standard management for the patients with aortic dissection. post-operatively, starting with beta blocker or heart rate slowing calcium channel blockers. Avoid strenuous exercise. These are some pictures which is following up the patients after aortic dissection repairing King Khalid University Hospital. As you see here, the Dacron patch in the MRI. Okay. As we can see here, the distal part in the thoracic aorta is still diseased, but can be managed medically. Our concern is about the first part, with the ascending and root aorta. I think everybody is seeing this video, or it's only me?
Yes, we can see it, Abdullah.
Okay. So this is aortic dissection. I have this message from the William Mayo. No one is big enough to be independent of others, especially in aortic dissection cases. I hope it was good enough lecture for today as completion of Dr. Ayat lecture. And this is the end of my lecture. Thank you so much. Any questions, please?
Thank you, Doctor.
الله يعطيكم العافية. عبد الملك خلاص. I think they went for pray. Okay.
Thank you. Any questions?
Nothing more. Thank you so much.
Thank you. So we'll take a 5-minute break, then we'll start the last session, inshallah.
Okay.
Dr. Abdelmalik, we can start.
دقائق بس لازم نزين حاجة أول بعدين نبدأ إن شاء الله.
تمام أوكي.
دكتورة روان تفضل you can start.
Assalamu alaikum. My name is Rana Ghamdi, cardiac surgery resident R1 at Prince Sultan Cardiac Center. Inshallah, today in our journal club, our topic will be about arterial versus venous conduit in CABG. I'll be talking about the arterial conduit.
So good afternoon, everybody. Sorry, Dr. Rawan. Yeah, actually, I was asking Abdul Malik, this is why we have some delay to create a pooling regarding the pooling is will be, are you pro one in CABG, are you pro one arterial, two venous, regarding the choice of conduit for grafting. So just keep this question, because we cannot do it actually. I don't know what's the problem. I'm supposed to prepare it before, sorry. And just keep this question in your mind, not you, I mean everybody, before hearing you and hearing also the other doctor who will be pro-venous. And after the discussion of both arterial and venous, just see if that will change your mind toward one kind or will give you another idea or another concept. Okay, this is for everybody attending now. Dr. Rawan, she will be pro arterial, and Dr. I think Al-Harthi, Riyadh. Dr. Riyadh, the second one, right?
Yes.
Hello?
ايوه رياض الحارثي.
Hello?
Hello.
Doctor, we hear you, we hear you. You can't hear us?
Yeah, now I can hear. Dr. Riyadh, you are the second, right?
Yes.
Okay, I'll start. And you can take a note and you can ask both of them at the end, okay? Yani everyone in the room keep, if you like, yani keep a note with you. At the end, you can direct a question to Dr. Rawan and Dr. Riyadh. Sorry for this, because it's supposed to be like a debate, but we'll take it today. This is the first time. There is a structural or structure scheme regarding how to run this, but today we'll just, as a trial, Dr. Rawan, she will start, give all her talk, trying to convince us that arterial is the best, and Dr. Riyadh, he will try to convince us that the venous is the best. Then we can ask both of them, and we will have a conclusion at the end. Sorry for this, and you can start. Thank you.
So the selection of the graft is important to the success of CABG, since the coronary conduit patency is directly linked with a normal post-operative course and an improved long-standing patient survival. I will go through studies that talks about the arterial versus venous conduit, the single versus bilateral internal mammary artery graft, the best second conduit, whether radial artery, right internal mammary artery, or vein graft, and finally multiple versus single arterial graft. The internal thoracic artery was first used as a conduit in CABG in 1946. Until the current practice, it is considered one of the most reliable and effective grafts utilized by cardiac surgeons due to its excellent durability. Superiority of the internal thoracic artery to the LAD was first disclosed in 1986 by Loop and colleagues from the Cleveland Clinic in an observational study that compared patients who received an internal mammary artery graft to the LAD with one or more saphenous vein graft with patients who had only saphenous vein graft in terms of 10-year survival, graft patency, and other cardiac events. From among the first 1,000 patients undergoing isolated CABG each year in the Cleveland Clinic, they choose in this study those who had a narrowing of 50% or more of the LAD, with or without other coronary arterial lesion, who received an internal mammary artery or vein graft to the LAD with or without other vein graft. They excluded patients with stenosis of 70% or more in the LAD, those who underwent emergency CABG, those who had a previous cardiac operation, and those who received a bilateral internal mammary artery graft, a sequential internal mammary artery graft, or internal mammary artery graft to vessels other than the LAD. Also, patients who died in the hospital were excluded. So this study included 5,913 patients. 2,306 received internal mammary artery graft, and 3,625 received a vein graft. The 10-year survival for patients who received an internal mammary artery graft was 86% as compared to 75% for those who had a saphenous vein graft. Among patients with single vessel disease, those with the internal mammary artery graft had a 94% survival compared to 88% for patients with vein graft. Among patients with two vessel disease, those with internal mammary graft had a 90% survival as compared to 79% in those with vein graft. Among patients with 3 vessel disease, the internal mammary artery graft had an 82% survival rate as compared to 71% for those with vein graft. In regards to the cardiac event, patients who had an internal mammary artery graft had a higher 10-year freedom from late myocardial infarction, hospitalization for cardiac causes, and cardiac reoperation than patient with vein graft only. Patient with the vein graft had a 1.41 times the risk of late myocardial infarction as compared to the patient who received the internal mammary artery graft, 1.25% times the risk of cardiac hospitalization, and 2 times the risk of cardiac reoperations. In regards to the graft patency, the patency rate of the internal mammary artery graft was 96%, and the vein graft was 81%. So in conclusion, the result of coronary artery surgery must be viewed over the long term. During the years of this study, they recognized that early patency was higher in internal mammary artery graft, but they didn't know whether those grafts improved survival or reduced post-operative cardiac events. 10 years after, sequential angiogram disclosed that late patency for mammary graft was significantly higher compared to the vein graft. This information, coupled with their finding of vein graft atherosclerosis as an increasingly common reason for reoperation. So there was a difference in the late development of atherosclerosis between patients with internal mammary artery and vein graft. This important difference in patency appears to be the major reason for the difference in late clinical result between the two groups. Here, this is a meta-analysis aimed to identify the clinical outcome with bilateral internal mammary artery versus left internal mammary artery to determine whether the use of the bilateral internal mammary artery has an increased long-term survival over other conduits. The primary outcome measured in this meta-analysis was survival, and it was defined as time from operation to death from any cause. So electronic searches was performed in 3 databases from 1972 to 2012. A total of 27 observational studies were included, no randomized controlled trial. 25 were retrospective cohort studies and 2 were prospective cohort studies. The 27 studies included a total of 79,063 patients. 19,277 were bilateral internal mammary artery graft, and 786 were left internal mammary artery patient. It included published studies that investigated at least 100 patients in the bilateral mammary artery graft approach and 100 patients in the left internal mammary artery approach, and studies with follow-up of more than 4 years. Duplicated studies, review articles, case report, conference presentation, and expert opinions were excluded. This meta-analysis demonstrated a statistically significant benefit in the survival for patients receiving bilateral internal mammary artery versus left internal mammary artery for CABG over other conduits. So with increasing evidence that shows long-term survival advantage for patients receiving the bilateral internal mammary artery graft, why are few patients undergoing this operation? The most often cited reason reported by cardiac surgeon is that the bilateral internal mammary artery is associated with increased early morbidity and mortality, specifically the occurrence of deep sternal wound infection and the well-documented increased risk of death that accompanies it. The deep sternal wound infection has been reported to occur in as low as 0.3% and as high as 14% of the bilateral internal mammary artery procedure, and is thought to be a result of the decreased sternal perfusion exacerbated by the bilateral versus unilateral harvest. In addition to the patient being diabetic or not, which is a known risk factor for sternal wound infection. However, in the diabetic patient, increased use of the skeletonized harvesting technique when performing a bilateral mammary harvest, along with other infection prevention strategies, have shown to reduce the rate of deep sternal wound infection. Currently, the majority of patients still receive only left internal mammary artery graft, despite the fact that the available evidence shows increased survival in patients receiving bilateral internal mammary artery graft. The operation is by all accounts for a more longer operation that requires more patience and surgical skills. Again, this is meta-analysis was limited by the nature of the studies included. Observational studies only, no randomized controlled trial has been reported with full long-term follow-up in this meta-analysis. Also by the fact the patient who received the bilateral internal mammary artery as their primary graft were on average younger, male, and non-diabetic. They also had a slightly better ejection fracture than those who received the left internal mammary artery. The ART trial, arterial revascularization trial, and compared to the previous observational studies, this is a randomized controlled trial that was published in 2019, reporting the outcome from the use of bilateral versus single internal thoracic artery at 10 years follow-up. It is a multi-center randomized unblinded trial at 28 hospitals in 7 countries, included a total of 3,102 patients. 1,548 were randomly assigned to undergo bilateral internal thoracic artery graft, and 1,554 assigned to undergo single internal thoracic artery graft. The primary outcome, as I mentioned, was survival at 10 years follow-up. Secondary outcome was development of myocardial infarction, stroke, rate of repeat revascularization, and safety outcomes, including bleeding and sternal wound infection. Eligible patients were those who with multivessel coronary artery disease who were scheduled to undergo CABG. patients for only single graft or if a valve surgery was planned, as well as those with history of CABG were excluded. Patients were randomly assigned in 1-to-1 ratio to undergo bilateral or single internal thoracic artery grafting. Both groups were matched with respect to age, sex, race, body mass index, smoking status, and coexisting conditions. This figure shows the flow of the patient through the trial up to 10 years of follow-up. In the bilateral group, as I mentioned, 1,548 patients were assigned to receive the bilateral mammary, and 1,554 were assigned to receive the single internal mammary. In each group, some underwent other procedure, some refused the surgery, some withdrew from the trial or died. At the end, 1,198 in the bilateral group are known to be alive at 10 years follow-up, and 1,189 were known to be alive in the single group. A total of 644 patients had died by 10 years, which account for around 20% of the overall trial population. 315 in the bilateral group and 329 in the single group. In regard to the development of myocardial infarction or stroke, there were 385 patients with an event in the bilateral group and 425 with an event in the single group. So there were no significant difference between the two groups. Also, there was no significant difference between the group in the rate of repeat revascularization. It was 10.3% in the bilateral group and 10% in the single group. There were no significant difference in the rate of early major bleeding. Sternal wound complication during the first 6 months of follow-up occurred in 54 patients, which account for 3.5% in the bilateral group, and in 30 patients, which account for 1.9% in the single group. So in conclusion, ART was a randomized trial that compared bilateral with single internal thoracic artery grafting for CABG at 10 years follow-up. There were no significant between group difference in all-cause mortality, in the rate of the outcome of death, myocardial infarction, stroke, or in the rate of repeat revascularization. The result of this trial are not consistent with the data from the previous non-randomized observational studies, where they suggested a potential benefit of the use of the second internal thoracic artery for grafting. And there are several possible reasons for the lack of evidence of benefit of the bilateral internal thoracic as compared to the single in this trial. First of all, 22% of those who had been randomly assigned to receive a single graft mammary also received a second arterial graft in the form of a radial artery graft. And there has been a growing evidence of the superior angiographic patency of the radial artery graft as compared with the vein graft. So the use of the radial artery graft in the ART may be confounder because it is likely to benefit the single graft group by the addition of an anterior graft to the second most important coronary artery. Another thing is that 14% of patients who had been assigned to the bilateral graft group actually received a single internal thoracic artery graft, which may have influenced the relative effectiveness of bilateral internal thoracic grafting. This crossover rate was higher than expected. So the high rate of non-adherence to the randomly assigned treatment result in a loss of the statistical power. There are several other potential limitations to be considered. ART was an unblinded trial in which the treatment group assignment was known to the patient investigator, to the care providers, and as a result, bias may be introduced in the treatment of the patient. Also, no follow-up angiogram or studies of myocardial viability was carried out, which limits the consideration of the graft patency. This is an analysis of the ART trial aimed to investigate the association between using the radial artery instead of the saphenous vein graft to supplement single or bilateral graft and the outcomes. The use of the radial artery, as I mentioned, has been associated with a superior angiographic patency rate compared with the saphenous vein graft, but whether this translates into a superior clinical outcome remains unclear. In fact, randomized clinical trials conducted to date are limited by small sample size, and the results are still inconclusive. So the ART trial, as I mentioned before, was designed to compare survival after bilateral over single left internal thoracic grafting. A large proportion of patients, around 20%, also received a radial artery graft instead of saphenous vein graft as a second conduit to supplement the mammary graft, making the ART the largest series of the radial artery grafting in the context of randomized trial involving single or bilateral internal thoracic artery. The primary outcome for this analysis was the major adverse cardiac event at 5 years, including cardiovascular death, myocardial infarction, and repeat revascularization. So the present analysis compared the strategy using the radial artery with or without additional vein graft versus the saphenous vein only to supplement the single or bilateral internal thoracic artery. Patients who were excluded from the analysis include those who neither saphenous or radial artery graft was used, patients receiving saphenous vein but neither single or bilateral internal thoracic artery, and patients receiving a radial artery but neither single or bilateral internal thoracic artery. So the final population included was 2,737 patients, 632 who received a radial artery, and 2,105 received a saphenous vein graft. The 5 years outcome, the rate of major cardiac, yes?
Almost maybe 7 minutes. You have
Huh? Oh.
7 minutes. How many time you need more?
Maybe 10 to 15 minutes.
You have to speed it up.
Sure. Okay.
Kindly. I forgot to tell you it is only 30 minutes
yeah,
to
sure.
finish your argument.
Okay, sure. So the 5-year outcome, the rate of major adverse cardiac event was 8.8% in the radial artery versus 13% in the saphenous vein group. So the use of the radial artery was associated with a significantly lower risk for major adverse cardiac event. Also a significantly lower risk for repeat revascularization in the radial artery group, which was 4.4 compared with 7.6 in the vein group. So in conclusion, the main finding of the present analysis is that a radial artery graft with or without an additional vein graft used to supplement either single or bilateral internal thoracic artery graft instead of the saphenous vein graft was associated with a significantly lower risk of, for major adverse cardiac event, with a significantly lower rate of reintervention and lower risk for cardiovascular death and subsequent MI. From these results, it seems reasonable to consider the use of the radial artery graft a valid option for multiple arterial grafting. The RAPCO trial, radial artery patency and clinical outcome, was designed to compare the long-term patency of the radial artery and compare with the most frequently used graft, the right internal thoracic and the saphenous vein. In the In the right internal thoracic versus radial artery, 394 patients were included. In the saphenous vein versus radial artery, 225 patients were included. The age group was 70 years of age or 60 if diabetic. They were randomized to receive radial artery or saphenous vein on the second most important target coronary vessels. Patient inclusion criteria included patient undergoing elective isolated coronary artery bypass requiring more than one bypass conduit, an ejection fraction of more than 35, and at least a one non-LAD vessel with a proximal stenosis of at least 70% and diameter of at least 1.5. Exclusion criteria included patient with body mass index of more than 35%, renal impairment with serum creatinine of more than 300, lung disease, major illness with expected survival of less than 10 years. The primary outcome was 10-year graft failure. The secondary outcome was the incidence of major adverse cardiac event, myocardial infarction, and repeat coronary revascularization. So in the radial artery versus right internal thoracic artery group, the failure of the radial artery versus right internal thoracic artery occurred in 15 versus 23 patients. The 10-year patency were 89 in the radial artery group and 80% in the right internal thoracic group. There was 11 versus 13 myocardial infarction and 22 versus 26 repeat revascularization in the radial versus right internal thoracic group, respectively. There were 50 deaths during the follow-up, 18 in the radial artery group and 32 in the right internal thoracic group. The 10 years estimate of survival were 90% in the radial artery and around 83 in the right internal thoracic group. In the radial artery versus saphenous vein group, the graft failure occurred in 6 patients who received radial artery versus 12 patients who received vein graft. The 10-year estimate of patency was 85 for the radial artery compared to 71 in the saphenous vein. There was 31 deaths, 39 in the radial, 31 in the radial artery and 39 in the vein group. The 10-year survival was 72 versus 65 in the radial artery versus the vein group, respectively. So in conclusion, this study found that the radial artery had a significantly better 10-year patency rate than the right internal thoracic artery and higher 10-year patency than the saphenous vein graft, also a higher 10-year survival. These findings support the use of the radial artery as the free conduit of choice to complement the left internal thoracic artery in the coronary surgery. Finally, multiple versus single arterial graft, the ROMA trial, randomization comparison of the clinical outcome of single versus multiple arterial graft. ROMA trial is a prospective unblinded randomized event, multicentric trial that estimate to include at least 4,300 patients. Patients will be randomized to single arterial graft or multiple arterial graft in a one-to-one fashion between the two groups. The primary hypothesis of the ROMA trial is that in patients undergoing primary isolated non-emergent CABG, the use of 2 or more arterial graft compared with a single arterial graft is associated with a reduction in the outcome of death from any cause, stroke, post-discharge myocardial infarction, and repeat revascularization. The secondary outcome, the secondary hypothesis is that in these patients, the use of 2 or more arterial graft compared with single arterial graft is associated with an improved survival. Inclusion criteria included primary isolated CABG patient with disease of the left main coronary artery or the left anterior descending and the
what the benefits of Roma? Why يعني why you are concerning about Roma? What Roma will answer?
Roma is still an ongoing trial. It will answer, despite there is a lot of research and several unanswered questions concerning the use of multiple arterial graft for CABG, the effect of a second arterial graft on post-operative outcome, the effect of using 3 or more arterial graft, and the relative role of the right internal thoracic artery and the radial artery as a second or third graft are all questions that have not been tested in an adequate randomized trial. So the Roma
I mean, you're right, but I mean, my question, we just have the result of our trial. So why many surgeons, they are exciting and they want to see the result of Roma trial? What was the problem in the ART trial when you presented?
The ART had many limitations, as I mentioned. One of them, it was unblinded. It was an unblinded.
Okay, and the crossover.
Yeah, the cross.
And the main things that will differ, the crossover. Actually, now you need to convince you. Your role today against Riyadh is to convince us that we will use an arterial, not the venous graft, right?
Yeah.
Type. Okay. Sorry for interruption. So just continue and give us your conclusion, so Riyadh can start his argument. Then we can discuss.
So just to finish this study, as I mentioned, the inclusion criteria, the exclusion criteria was any patient over 70 years, patient with a single graft, emergency operation, evolving myocardial infarction within 48 hours of surgery, left ventricular ejection fracture less than 35, previous cardiac surgery, inability to use the saphenous vein or use both radial and right internal thoracic, and planned hyperdrevascularization. So as I mentioned, this is an ongoing randomized comparison of the clinical outcome of single versus multiple arterial graft, aimed at examining the effect of multiple arterial revascularization during CABG. Despite many researches, several unanswered questions concerning the use of multiple arterial graft for CABG still remains unclear. The effect of a second graft on the post-operative outcome, the effect of using 3 or more arterial graft, and the role of the right internal thoracic artery and radial artery as a second or as a third arterial are all open questions that have not been tested adequately. So the Roma trial was conceived to provide answers to those open questions. Thank you.
So just kindly, what is your, and give us like a statement as a pro for arterial graft?
Many studies, many meta-analysis and randomized clinical studies, most of them, they all support the use of whether a total arterial, multiple arterial graft or a second arterial conduit in relation to the survival, the patency, the major cardiac event.
Okay, but we'll come back. I don't want to play devil advocate now. Riyadh, Dr. Riyadh.
Yeah.
Okay, Dr. Rawan, great presentation. Actually, thank you very much for the presentation. But we will have another discussion after Riyadh. Riyadh, how many minutes you will need to give us your argument?
I will try 20 to 15 minutes.
Okay. So it's better. Yes, try just to go quickly. Give us why we should go for in cabbage just to use a venous graft.
Okay. Assalamu alaikum. I am Riyad Al-Harthi, cardiac surgery resident at Kathafa. So objective, it will be, I will talk about venous conduit, and the objective, it will be start from introduction, and there is paper study of randomized trial, no touch stiffness pain of cabbage after 16, maintain the patency or after 16 years, comparable to Lima, and there is a longitudinal randomized trial of no touch cabbage of the preserved left ventricular ejection fraction at 16 years. And there is a structural observation and impact on graft performance, 25 years of no touch stiffness pain harvest for cabbage. For the time, I will skip off the introduction. The first paper,
Go back with the limitation. Go back, please.
Limitation of what?
Arterial grafts are associated with limitation.
Arterial grafts are associated with the limitation.
Because Riyad, now you will argue, okay, that the venous is better.
Okay.
Right?
Okay.
So you think this slide is important or not to convince us?
Yes, sure. Arterial grafts are associated with the limitation.
Just a minute, Dr. Rawan, just take a note of this one to answer, to reply later on him regarding this slide. Fadl, sorry, Riyad.
Okay, arterial grafts are associated with the limitation such as an increased incidence of mediastinitis, particularly when using bilateral internal thoracic artery in patients with diabetes. Poorer results when bypass target vessels with stenosis less than 70, spasm that are common in free arterial graft, risk of ischemia after removal of arterial graft. So the first paper, it talk about the no-touch vein for coronary artery bypass, maintain patency after 16 years, comparable to left internal thoracic artery. It's a randomized trial. Randomized trial was initiated in 1993 to compare three harvesting techniques, the angiographic assessment of graft patency that were conducted at mean time of 1.5 and 8.5 years. Post-operative demonstrate a significant better patency rate for the no-touch group. The primary aim of this longitudinal trial is to examine whether the no-touch vein graft still maintain a significant higher patency rate than conventional vein graft. Secondary aim is to determine whether the patency is still comparable to that of LETA at mean time of 16 years. Stiffness veins are conventional harvested by stripping them from their surrounding tissues, causes graft spasm, and then dilating them with normal saline or blood to overcome this spasm. This is a known cause of vessel wall damage. And the no-touch technique is harvested with a pedicle of surrounding tissue. This technique has been shown to reduce risk of spasm and need for dilatation and therefore preserve vessel wall. Method of study of design, single-center randomized clinical trial, 156 patients were enrolled from 1993 to 1997. Three groups of 52 patients each according to three stiffness harvesting technique. The first is a conventional group, stiffness vein was stripped and distended with saline. Second is intermediate group, stripped but not distended. And the last is no-touch group, the Cephinus was harvested with fat pedicle. All patients were to receive LETA to the LAD artery. This is a flow chart of longitudinal flow up. We have conventional and intermediate and no touch, 52 patients each group. After 1 year and a half in conventional, there is no death, and also in the intermediate and no touch. After 8.5 years, there is 4 deaths in conventional, and in the no touch, we have 3 deaths. But in the intermediate, no follow-up due to financial limitation and loose patency at 1 year and a half. After 16 years, we have 10 deaths of conventional and 10 deaths equal of no touch. Angiography is the study flow-up conventional and no touch at mean time of 16 years post-operative. The first 2 follow-up at 1.5 year and 8.5 year were performed with conventional coronary angiography. The third follow-up occurred at mean time of 16, range 14 to 18 years, and was performed with CT angio. This picture of post-mortem of conventional and no touch, we can see in the conventional of at 8 years, there is considerable necrotic friable tissue and diffuse atherosclerotic process, and the atherosclerotic process in the no touch was less pronounced, more localized and organized after 9 years, 12, and 18. This table is ratio number of patent graft to total number graft. We can see in the conventional and no touch. After 16 of conventional, patent graft of single is 65%, whereas the no touch is 82, and all we can see 64% after 16 years and 83 of 16 years and no touch. This table, coronary artery and vein graft characteristics in 2 randomized study group of conventional and no touch. We can see in the less than 40 graft flow millimeter per minute. After 16 years, we have 55%, and in the no touch is 81%. In the venous quality of bore, we can see after 16 years is 38, and in the no touch is 89%. In the Cephinus vein from distal to proximal, we can say after 16 it's 73, then 62, then 55. And other side of no touch, it will become proximal is better 90, from proximal medial 81, and distal is 78. Result, 54 patients were included, conventional group 27, no touch 27, Cephinus vein graft patency was 64% in the conventional versus 83 in no touch, which was similar in the patency of LETA 88%. The harvesting technique had major impact on the patency with hazard ratio of occlusion of 1.83 for conventional group. From original 104 patients, died 14 in conventional, 13 in no touch, and cardiac related mortality is 6 and in the conventional and 4 in the no touch. Risk of wound complication is higher in the leg, require vein graft to be harvested from the thigh. No touch had poor quality vein, 11% in conventional, 24 in no touch. No touch higher percentage, smaller target vessels, 60% conventional, 76 in no touch. 4-fold increase graft with considerable intimal hyperplasia, and second-fold increase graft with oblique atherosclerotic in conventional, rather than no touch graft. Conclusion, the Cephinus vein can still consider a reliable conduit for cabbage harvesting Cephinus with no touch technique at mean time of 16 years. a significantly higher patency than conventional technique that was still comparable to the later. To achieve such result, the saphenous vein should be harvested using no-touch technique. Second paper is the no-touch vein graft for coronary artery bypass. Preserve the left ventricular ejection fraction at 16 years post-operative. Long-term data from a longitudinal randomized trial. It's randomized trial, the no-touch coronary artery bypass, shown superior patency of and slower progressive atherosclerotic and better clinical outcome compared to conventional vein graft at 8.5 years. All patients at meantime 16 years were offered an echo and clinical examination. This is echo result after 16 years of no-touch and conventional. We can say in the ejection fraction, in the no-touch is 57.9 plus minus 9.5, and ejection fraction in the conventional is 49.4 plus minus 13.3. And in the left atrium size increase in centimeters, we can see in the no-touch is 21.7, and in the conventional is 23.9. This is clinical outcome after 16 years in no-touch and conventional. The mortality is 13 in no-touch and conventional 14. The cardiac related is 4, in the conventional is 6. We can see in the MI 5 in the no-touch and 10 conventional. And BCI, we can, it's equal, both group, no-touch and conventional. Result, no-touch, 34 patients, and in the conventional group, 31 patients underwent echo, better left ventricular ejection fraction in the no-touch compared to the conventional. The size of left atrium was in no-touch 21 compared to 23. Number of patients no-touch, no patient no-touch has AF compared to 5 patients in conventional. Patient with BMB more than or equal 150 was 30% in no-touch compared to 38 in conventional. Total mortality 25% versus 27 in conventional. Cardiac related were 8% and 8% in no-touch and 12 in conventional. Conclusion: the long-term echo follow-up no-touch harvest technique as compared to conventional showed profit preserve left ventricular ejection fraction after mean time 16 years and inferred improved left ventricular diastolic function. Smaller left atrium, lower BMB and no atrial AF indicate improved diastolic left ventricular function in the no-touch group. The third and last paper, 25 years of no-touch saphenous vein harvesting with coronary artery bypass, structural observe and impact on graft performance. This is saphenous vein of structural and vascular damage. We can see in the left panel no-touch. No-touch quotient, no-touch half quotient of the fat is intact and not to be distant. And the conventional fat is removed, distant overcome spasm. No-touch is intact of prevascular fat and undamaged adventitia, adventitia and thick of media. Facial not to be distant and lumen thrown into the fold. In conventional, we can see there is various form of damage. Adventitia is stripped off, media is thinner, and lumen is dilated. This is picture of histological, cellular, and ultrastructural no-touch and conventional. Top panel are represent example of part transfer section through the wall of no-touch and a conventional saphenous vein. Intima surrounding lumen no-touch saphenous thrown into the fold. The vein wall is thick with small muscle of the media and intact of adventitia. Intimal fold in conventional absent, and visual wall thinner than the visual wall is thinner than the no-touch. of the media, and adventitia is removed, mostly be removed and damaged. We can see here in panel A is intact endothelial lining in no touch when compared to conventional vein. With panel D, we can see it's loss of endothelial lining. In the panel P, uniform shape and disruption of vascular smooth muscular cell in the M of no-touch saphenous vein. The smooth muscle in the M of conventional is very different. Panel C is intact fasa, intact of fasa phasoram, and with intact of adventitia also in the conventional the fasa phasoram it's and adventitia is mostly be removed. The question arises while arterial conduit, internal thoracic artery and radial artery are generally removed with pedicle intact, why should the saphenous vein be harvested with pedicle removed? Endoscopic vein harvesting, this method harvesting reduces leg wound complications such as infection, pain, numbness, and improving cosmetic result. Endoscopic was rapidly adopted and now used in many centers worldwide and the majority of CABG operation. There are conflicting reports regarding of the patency of saphenous vein. When considered endoscopic patency is the best, comparable to open patency. It seems reasonable to assume no-touch saphenous will be superior to the prepared by endoscopic. The National Institute for Health.
Yeah, Riyad. Go back one second. Like there are conflicting reports regarding the patency of saphenous vein graft. I don't know because there is a trial done comparing open versus an endoscopic vein harvesting. You will talk about that trial?
No, I will not talk about what exactly.
Open versus endoscopic vein harvesting.
No, I will not talk about that.
Okay, because it is right that there is some report retrospective analysis showing that there is conflicting reports, but in that trial showed no difference.
The National Institute for Health and Care Excellence previous guidance advised that endoscopic should only be used with special arrangement. Endoscopic graft showed higher failure rate than open. More recently, on large number of patients, NIC concluded that there was no increased occlusion rate or higher incidence of death, myocardial infarction, or re-intervention for endoscopic harvested graft. Increased hospital cost of endoscopic and importance of training and regular experience for any clinician and doing this procedure. This picture of saphenous vein histology of endoscopic vein harvesting, no touch. We can see in the prevascular rail and endothelium are damaged, and the row is time altering. Middle panel, we can say this is small incision for endoscopic above of the knee and compare it with open of harvesting. In the right panel, no touch harvest, saphenous with prevascular fat and adventitia intact and endothelium undamaged. There is no debate that no-touch harvesting technique of saphenous is less traumatic than the conventional technique. With the available evidence, preservation of prevascular tissue on the no-touch conserves normal vessel architecture, protect against this, distension-induced damage, and maintain endothelial nitric oxide resettling in severe long-term results. The guideline of sevoflurane, no touch, now recognized as Class 2A recommendation in 2018 European Society of Cardiology and the European Association of Cardiothoracic Surgery guideline on myocardial revascularization. The question is, what will you do, venous or arterial, and why?
Yeah, this is your summary. So what you will do?
For myself, until now, I will do with venous because until now there is no randomized controlled trial showed the difference in the survival, and many trials showed no difference between of them. And also most of the study didn't use optimal medical therapy. And also the vein is delicate and different technique of harvesting may affect of the patency.
Okay, Dr. Rawan.
Hey, Doctor.
So same question to you, what you will do, venous or arterial, and why?
I would use the arterial if it's depending if it's not an emergency case, if the patient is depending on the age group, the life expectancy, I would go with arterial.
Okay, so I will, the floor, kindly the one who want to ask, just raise your hand, and we'll give like 5-10 minutes for the discussion of the two, doctors here. Or you can give any comments. For the audience.
Maybe Aitam, you can give us your conclusion.
Okay. First of all, thank you, Dr. Claudio. Of course, at the end, we will have your opinion to sum up this discussion, of course. First of all, for me, we need first to remember and to have what is in the guideline, what is in the current guideline. This is the most important things. In the European guideline 2018, they upgrade the radial artery as a class 1B for high-grade stenosis to be used. Lima is a class 1 and Pima is a class 2A, and also to use it as a skeletonized if risk for any sternal, if you have a risk of sternal complications. Even in the 2016, the STS clinical practice guideline for single or internal mammary artery is a class 1 to be used in the LAD, and class 2A for RIMA or radial to be used as a second to Lima as a second arterial graft. Use of the bilateral in patient who have who didn't have an excessive risk of sternal complication. A big study was done in the Cleveland Clinic showing that doing bilateral skeletonized arterial artery will decrease the risk of sternal wound infection, and the high risk group for bilateral internal thoracic artery, the obese patient, the patient with COPD, very old patients. It depends on the circumstances, as Dr. said. The use of no-touch technique in the vein graft that can actually be used in open and also in endoscopic technique, but with a trained physician or surgical assistant, he can use it because it showed a better result or outcome in multiple series, as in this too. And now the evidence actually is accumulating, especially the meta-analysis for the radial artery. If you have any stenosis more than 70 or critical stenosis, the benefits of using the radial artery as a second conduit will be best. Roma, and why the Roma now it's came because of the art in the art trial, because of the cross, what they call it, the cross. The crossover between the groups that the group was analyzed was very high. I recall it was 16%. Dr. Rawan, she mentioned it, and also the patient reaching 20% was analyzed. 20% patient analyzed to have a single arterial graft, which is Lima, and actually, in fact, they have radial on top of that. So the evidence regarding arterial grafts is actually convincing to me personally, but if you take it as general, yes, our trial didn't show any survival benefit, but if you go to subgroup analysis, you will see that difference. And the most important things, in my point of view, the selection of the patient and the experience of the surgeon, how to deal, how to harvest radial, how to harvest internal thoracic, how to have a correct selection for the patients, yani 60-year-old female obese, you will not go and do for her bilateral internal thoracic artery, even skeletonized, because this will increase the risk of mediastinitis, and this is something you don't want. Young male, no other problems. There is a lot.
But in that patient, you will use a radial if you have the
yes.
right.
Yes, the radial.
We tend to use a radial in female. That's your picture of female. We tend to use the radial. I don't want to use vein in that female because I want the patient to get out of bed as soon as possible with the best result. And the radial gives you all these advantages beside that, you know. Anyway,
yes.
Sorry to interrupt. The other things I want to say about the art trial that was not mentioned. The art trial, as randomized, gave the results that Rawan reported. But if you go to the analysis as treated, well, there was an advantage. So the advantage was there in the as treated. We know that as treated doesn't count in randomized trial and blah, blah, blah. But if you consider the patient who received Lima and plus the radial as arterial revascularization, and you go for as treated, well, in those who there was those who were treated with arterial graft, the advantage was clear. So the art trial was inconclusive, but this crossover, prompted the conceiving of the Roma trial, which is ongoing. You know, as we are waiting for the result. We'll see. But there is evidence that the radial artery can be safely used, improving, you know, your long-term results. You're right. I don't think there is any competition between vein and arterial grafts. They are complementary. I try to make you understanding we are all here making the discussion because the Lima on the LAD proved so superior that the adult cardiac surgery could survive, and coronary artery bypass graft is still the most common surgical procedure in the United States and all over the world. So it is an arterial or on a coronary artery. The assumption that the more arterial are more beneficial still needs to be proved, but we have to keep going, and you have to think in this way. Try to divide your coronary revascularization in three sectors: the right, the Lima, the LAD, and the circumflex. So there is no doubt that you are putting a Lima on the LAD. Nobody is, ask yourself, what is the best conduit on the right coronary artery? Some of you, we may say, is a Rima. Wrong. Actually, the RIMA is the worst. Yes, the RIMA don't have the idea that the RIMA on the right coronary artery is the best. Is not true. Actually, it's the worst. The best is the radial, provided that you have a tight stenosis, provided that you have a good coronary bed, is a good runoff. Otherwise, put a vein. There is no shame in that. Absolutely. I put a vein whenever it is indicated. It's a vein. It's most welcome. Where is the fighting? The fighting is on the circumflex. The fighting is on the circumflex because the two arterial grafts are beneficial only if you put them on the left system. There is no way that putting two arterial grafts on the right, with one on the Lima on the LAD and the other arterial on the right, will definitely improve so much your benefit. No, your survival is on the left, and the fighting is on the circumflex, which, by the way, is the most is the coronary bed, which has the highest kind of variations. How many kind of anatomical LAD 2 or 3? How many kind of right coronary and PDA 2 or 3? That's it. How many kinds of different configuration of the circumflex I cannot tell you. So many. So that's why it's very difficult to assess the quality of your result. The radial artery, if you are not going for the two mammaries, is your solution, because it's as easy as a vein. It is durable. It is so you're comfortable, as comfortable as like a vein, without being the coronary, the arterial coronary surgeon that makes Y and harvest both skeletonized. The other things I can tell you, the guys at Prince Sultan, the resident, take the mammary skeletonized. At least when they are with me, they can do that. And the point is, start with skeletonization, because it's extremely helpful. Will take a little bit more time, but the young guys who are willing to be a cardiac surgeon, I would like to show you, if you give me the screen. I would like to show you a picture that I had an impression. I had a big discussion with my friend. Do you see that? Do you see the
Not
no?
yet. You just go, share screen, and you can share your screen.
Okay. I have to go to share screen. I had a big share screen. Okay.
Bottom share screen, just hit on it or click it, sorry.
No, sorry, I have to, yes, I have first to open this and then go here. I had a big discussion with the share. Look, do you think this is a surgical case? I think so. There is a left main, bifurcation here. There's another stenosis here. This is the LAD, stenosis. Well, no. This picture was taken in a big discussion with my friend, Professor Gaudino at the university. Because you have noticed that probably in the RAPCO and in the art there and the name of several Italians. And there was a discussion. Do you think this is a surgical case? What shall you do with this one? Actually, this was the commercial, the advice, the picture that was in a PCR meeting of cardiologists, how to do bifurcations. So they do these cases.
Really?
These cases was treated with a PCI. Okay. So if we do not offer in the future to our patient excellent result, if we think that just a mammary and two veins will solve the problems, we are wrong. There is a continuous research And there must be a continuous pressure on surgeons as well to improve the quality of their revascularization. Because there is such a pressure of the industry on the stent and on the PCI, and definitely there are benefits. I tell patients to go for PCI many times, you know. But on the other hand, we need to be committed to offer the best. Not necessarily the arterial revascularization is for everybody. I see whether I can. I don't. Are you seeing this the movie?
Not the movie. Still picture.
Still the picture. Okay. We have to commit ourselves, and I think for the young guys that the first step is to commit to start harvesting the mammary as a skeletonized artery. You know, this is the first step to get the confidence. There will be a time that you will have the patient relatively young, good vessels, not diabetic, or that you will say, okay, if you have the confidence for the left, I will harvest the right. And I tell you, the right skeletonized easier than the left. You know, those who fear, no, the skeletonizing the right is easier than skeletonizing the left. So with growing confidence, you will increase also, but you have to commit. That's the only point. And you don't have to think that you know, the result has been acquired forever, one mammary and two veins. That would be, it still would be the most common procedure, yes, but you have to accurately choose your patient, and you can do that. That's my message to the young guys, and that's why I stay here on a Thursday until 5:15 with the young guys. You know, okay. My day today was dedicated to the young. The young Khalid Al-Oteibid, he did his case. I followed Rawan. And I want to tell a message to these guys: commit yourself to coronary revascularization, because it will be anyway 80% of your job, and you have to improve the quality, and you have to go the step beyond. That's all. Thank you,
Dr. Claudio.
Thank you very much, boss.
Doctor, I have only one question. Why you compare the right and left? So if I know how to do the left, then I will know how to do the right one.
Yeah, of course.
Yeah, because you're saying it's more difficult or something.
No, the right actually is easier. Most of the times it's easier. You will be surprised that it will be easier to harvest the right than the left. So it's just, you have to be confident. It takes time, takes commitment. You have to be confident, but it definitely can be done. And all these studies, I mean, the subgroup analysis, and of course also the Cleveland Clinic tells you that when you harvest two mammary skeletonized, you don't have to worry about the myastinitis, you know, the deep sternal wound infection. That's it. I would like to see whether we can get. I'm still in new share. Probably this one.
No, you are in share actually. We see the picture of the angio still.
Yeah, but I don't know how to make this. Let me see.
Just exit, Doctor. Get out of this picture so you can share another one. But keep sharing.
Okay.
Get out of this.
Okay.
Exit. Yeah.
Okay. I don't know whether this.
Yes.
Yes.
Now we can see it.
So this guy, yeah, So you can see this is a radial artery, which is what was anastomosed with stump of the right corner of the right mammary. So here there is a end-to-end anastomosis, and we tested the flow. This is a Y with two. This is the left, the lima, and this is the rima anastomosed. And this guy had three graft and an aortic valve replacement. So is it definitely possible? And everything was harvested by the registrar and the resident. That's all. I just did I did the anastomosis, but there will be a time you will do the anastomosis. But everything was I did not harvest any of these conduits. So you can commit, you can do that. Okay.
Thank you. Appreciating, boss.
Thank you. And I have to say, Mabruk, everybody. It was really interesting. You know, the commitment of the guys was excellent. All the presentation was very good. I spent an interesting afternoon, I have to say. Okay. Thank you so much for your patience.
Inshallah, we'll create. They spoke with me. Maybe we'll create a debate for AVR versus TAVI as a debate. One will be pro TAVI, one will be
the
pro
message for
AVR.
me there is the message for me is there is no competition between vein and arteries. There is no competition. You have to use the right conduit for the right person. That's all. So there is no, this is superior, this is actually the benefit of arterial revascularization is lost after the age of 70. So you have to choose your patient. Rawan was right. You have to choose the patient and you have to do the right thing. That's all.
Yes, even in the guideline now, they upgrade the radial to be class 1. It is class 1 indicator. This is why I start my talk, because for the guideline and the subgroup analysis or the crossover that happened in the ART trial. So we have to stick to that. But because there is still the arterial grafting, even with the radial artery, it is now it's a class 1 indication, or before it was class 2A, I recall, or 2B, I'm not sure. But it wasn't used widely in the world everywhere. But now this is the evidence, the guideline, and this is the evidence, and this is how we will move forward, I believe. Especially,
I think I was speaking with some guys in US. They have quality parameters for their revascularization, which also somehow it reflects also in the reimbursement they get. And I think that soon the AATS and the STS will put the use of two arteries amongst these quality criteria now. So also the number of arterial revascularization will increase in the United States, and that will push the world a step forward. But there is no need. I mean, if you go in Europe, except for UK, they are very conservative. But if all over Europe, Italy, France, Spain, Germany, they do arterial revascularization whenever possible and reasonable. That's for sure.
Yes. Thank you. Any further question to Dr. Claudio or to the two presenters, Dr. Rawan, Dr. Riyad?
No, thank you.
From anyone in the audience? Thank you again, Dr. Rawan and Dr. Riyad, for excellent presentation. Special thanks, of course, to Dr. Claudio and to all of you. I don't know, from the resident side, who's the one responsible? Abdel Malik, you are here to conclude, or?
Yes, Haitham. Thank you, everyone, for this presentations. Thank you, Dr. Claudio. Any other questions? So by this, we'll end our session for today. Dr. Loai, he came. Thank you.
Assalamu alaikum. Sorry, I joined late.
I
would like to thank all the presenters. Not sure, Haitham, what's your evaluation about the debate?
We'll discuss
would
later
like to
because
continue,
we kept Dr. Yes, we'll discuss later because Dr. Claudio, actually, thank you to him. He's here since 1 p.m. and we need to conclude. I will speak with you.
No problem. Thank you, Dr. Claudio, for coming.
Thank you,
everyone.
guys. Have a nice weekend, everybody.
Have a nice everybody. Thank you.